Very good morning to you all. I think in the interest of time, I think we'll start the session. I hope more people will join as the session progresses. Well, we all know that handling a calcified vessel PCI has its own tips and tricks. A lot of difficulties we faced in the cath lab. Most of the times, if we don't plan well, we are unexpected directions the procedure takes. Of course, now with the advances in or the routine use of imaging and routine use of lesion preparation with atherectomies and IVL balloons, things have become much better. Still, there are a lot of issues which one has to improve in. I think in the next the lectures which are going to follow, we are going to be more intelligent on these aspects. I think we'll start with the first topic. If Dr. Jyotsna is here. Dr. Jyotsna is here? No. Then Dr. Keval is here. Yes, yeah. Then Dr. Keval, can you come onto the stage?
Good morning to the respected chairpersons and the faculty. Today I'll be discussing a case of rotablation of a left main bifurcation in a patient who is post-CABG. So the patient is a 52-year-old non-diabetic male, underwent a CABG at an outside center 5 months ago with a lima to LAD and venous grafts to the circumflex and the PDA. Present to us with an NSTEMI, elevated troponins. LV function was essentially just mild LV dysfunction, EF of 45 to 50%. CT coronary angiogram showed occluded SVG graft to RC as well as OM and an atretic lima. We took the patient for a conventional coronary angio. The angio showed critical distal left main bifurcation disease with disease of the ostial circumflex as well as the ostial LAD. And we can see that the distal LAD is occluded beyond the site of the anastomosis of the lima to LAD. Again, we see that lima is occluded at the site of anastomosis with no filling of the distal LAD. And RC angiogram showed around 70% calcific disease of the proximal to mid RCA. We thought that the RCA, we can keep him on medical management for the time being, so we decided that we'll do a left main bifurcation with imaging as well as use of a rotational atherectomy. First of all, we started the patient with a femoral excess 7 French EBU guiding. We wired the LAD first of all. We tried with a routine BMW wire. We were not successful with that, so we shifted to a Whisper MS wire. Started with the use of aux microcatheter, but the microcatheter could not cross the distal left main lesion. So we shifted to a new NY fine cross microcatheter. Again, that was not successful. We could not cross the microcatheter beyond the lesion. So at this point, we decided we'll use a 1 millimeter balloon to dilate the distal left main lesion. So in the figure in the center, we can see that a 1 millimeter balloon could cross the lesion. We dilated it at around 12 atmospheres, so we could make room for the microcatheter to cross the lesion. And then we rotablated the LAD and the proximal left main with a 1.5 millimeter balloon at 165 lakhs RPM. Did a polishing run for the LAD, subsequently followed it up with rotablation of the circumflex. We can see there was some difficulty in rotablating the circumflex, but again we were successful. Subsequently, we pre-dilated both of these with 2.5 millimeter non-compliant balloons. Then we did an intravascular imaging, which I'll be showing in the next slide. Following the intravascular imaging, we dilated the LAD with a 3.5 millimeter non-compliant balloon and a 3.5 millimeter Wolverine cutting balloon. So the figure on the left is the IVUS run from the LAD, and on the right is the IVUS run from the circumflex. So I'll come to the most important parts. We can see some calcification of the proximal LAD, calcium arc of around 90 degrees. And when we come to the distal left main, we can see there is almost a napkin ring calcification 360 degrees with some calcific nodule at the distal left main. Again, on the imaging run from the circumflex, we can appreciate that there's around 90 to 120 degree calcium, and when we come to the distal left main, it's almost napkin ring calcification with calcific nodule of the distal left main. We'd already done rotablation. We had already pre-dilated with high pressure NC balloons and already did a cutting balloon for the ostial LAD. We took the first stent, 2.75 to 15 millimeter Zynes, and placed it from the ostial circumflex, and subsequently crushed the stent with a 3.5 millimeter balloon placed in the LAD. Followed it up with the first recrossing, a non-distal recross, and did the first kissing balloon with 3.5 in the LAD and 3 millimeter balloon in the circumflex. Then placed the second stent from the ostial left main to the proximal LAD, a 3.5 millimeter into 23 Zynes prime stent. Did the first spot with a 4.58 millimeter balloon. Then distal to the stent in the LAD, there was some dissection, so we covered it up with another stent, 2.5 to 24 millimeter from the proximal to the mid LAD. Followed it up with final kissing balloon dilatation, 3.5 millimeter in the LAD and 3 millimeter in the circumflex. And in the figure on the bottom left, we can see that there's some haziness at the ostial circumflex. At this point, we thought we'll do a kissing balloon again. The possibilities over here included it could either have been a thrombus, it could have been a tissue prolapse, or it could have been a slightly longer neocarina. Or this appearance could also be because of the presence of a calcified nodule at the distal left main bifurcation. Hence, we did an imaging run. In the imaging run from the LAD, everything looked fine. However, if we look at the distal left main, although the area at the proximal LAD was fine, but the distal left main seemed to have a slightly longer neocarina. And in the imaging run from the circumflex also, although the ostial circumflex looked fine, but we can see that there's a slightly longer neocarina. Possible causes would have been that it might have been a slightly distal recross as compared to what it should ideally have been. We thought it could have been a thrombus. We repeated the ACT. ACT was fine. We also repeated some heparin. Again, we had done a kissing balloon dilatation with a slightly larger balloon, 3.25 millimeter in the circumflex and the 3.5 millimeter in the LAD. At this point, the possible options could have been that we could have tried to rewire again, but that once we've already done a kissing balloon, another proximal rewiring becomes slightly difficult. We took the final angiograms. There's some haziness in the ostial circumflex. Apart from that, the result looks fine. The distal LAD is again a CTO with no filling either from the lima or from the RCA. And we decided we are not going to address the distal-most CTO because there are a couple of diagonals and good septals being perfused from the LAD. Final result appears fine. Patient has now completed 4 months of follow-up. Patient had just come for follow-up a couple of weeks back. Patient's doing fine. No further more events. We did not address the RCA because it looked non-critical, around 70% stenosis. The take-home message is that for such lesions, when your microcatheter cannot cross the lesion, you might want to pre-dilate the lesion with a small balloon. However, it is very imperative you do not use a very large balloon because it can cause extensive dissections which may prohibit you from doing rotational atherectomy. An adequate lesion preparation using rotablations, cutting balloons, IVLs, OPNs are mandatory in these cases. In this case, I did not use an hemodynamic support device because the patient's LVEF was normal, although we did have backup facilities for an IBP if required in the lab. Thank you.
Very, very good case. Very well handled.
Thank you, sir.
I think. We have. What you did, everything was right. There is no. That haziness in the final run of IVAS, it did look like a calcium?
Sir, in the IVAS run also, it did not look like a calcium, although we read the literature and there have been cases where you do not see the nodule on the IVAS in the post-angioplasty run, but it has been said that the presence of an underlying calcific nodule may give you an appearance of such an haziness.
It's very common.
Yes.
It's a very interesting case.
Thank you, sir.
Regarding the neocarina that you mentioned.
Yes.
Normally when we do DK crush, it's always imperative that you need to have the first crossing more proximally.
Exactly.
The second crossing, when it comes to more proximal strut, what you have is you end up having a metal carina.
Yes.
So the second crossing, if at all not very carinal, it should be at least the mid crossing.
It should not. It should be a non-distal cross.
That's number one. And secondly, it was very, very difficult wiring in this particular situation.
It was quite difficult. Yeah.
I felt that looking at the spider view, I thought that it might be extremely difficult to get a wire into LED. Probably you need to have a reverse loop to get into the LED.
Yeah.
And secondly, regarding the microcatheter that didn't cross, we have the OTW balloon 1 millimeter. You had the regular 1 millimeter
We had the
balloon
regular 1
going
millimeter
across,
balloon, yes.
and then you had to change it over to a microcatheter
Yes.
and then go across.
Yes, yes.
With the OTW balloon, you can dilate it, push it distally, take out the wire and go with the rotafloppy over the balloon itself.
Unfortunately, we do not
It's
have
not-
OTWs
It's not
in our...
routinely available.
It's not available on the shelf in our
Very
lab.
nice.
So, yes. Thank you.
Thank you, Dr. Cable. I think we'll move on to the next presentation by Dr. Gaurav Verma. Dr. Gaurav is here? No. Dr. Nimit Shah? No. Arun Gopi? Yeah. Welcome, Dr. Arun Gopi. I think he'll be talking on ripple whammy anomalous calcific dissected RCA bailout with rota. So, interesting title.
Yeah, so it was actually a triple whammy. So it was a triple whammy, and we're dealing with an anomalous calcific dissected RCA. How rota helped in bailing out this situation. So, stories of a 67-year-old diabetic hypertensive had inferior wall end STEMI with intermittent AV block. Echo showed preserved LV function with wall motion in the RCA territory. Underwent an angiogram in an outside center. RCA was anomalous and had a critical calcific stenosis. Attempted PCA from that center, but as per the reports, they couldn't engage the RCA properly, so PCA was left. So he came for a reattempt PCA in anomalous RCA with a calcified lesion, and they had already financial constraints because already they had exhausted some finance at the first center. So this was the angiogram. So RCA was almost from the mid left sinus, calcific proximal to mid segment, had intermittent AV block, so a temporary pacing was put in, right femoral axis, 7 French. We tried, since it was coming from the left sinus, we tried JL3, JL3.5, EBU3, EBU3.5 and AR. It didn't engage, probably because of the distance from the left coronary artery. Finally, an AL1 7 French engaged, although it was non-coaxial. We used a fielder to cross the lesion, but the smallest, even 1 mm balloon did not cross. The IVUS catheter we attempted, it was futile, but we tried to just understand what was there. We tried to pass the IVUS catheter, it got stuck in the calcium and finally damaged the IVUS catheter. So we exchanged the fielder over a caravel. Caravel didn't track down, but it tracked to the maximum track point and exchanged it to a Grand Slam to improve our support since it was a non-coaxial guide. So on the non-coaxial guide, we tried to make it coaxial in different angles, but we just failed. So we tracked a 6 French guidezilla over an inflated balloon inside. The guidezilla definitely went till almost the mid segment where the typically significantly calcified segment was there. But this guidezilla definitely helped us in crossing, getting serial balloons down. We got a 1.28 balloon, 1.5, 12, 212 balloon dilated down. We initially thought everything looked well, so we thought it was all going in line. Suddenly, when we had a turnaround, when we took a 2.5 non-compliant balloon, and you typically find that dog boning, the 2.5 non-compliant balloon was not yielding. So we went down the size, we went to a 2.25 12 balloon at 28 atmospheres. Even then it didn't yield. You can typically see the dog boning, and we tried with futile attempts to track a cutting balloon or scoring balloon. Both didn't track. So there was a unnoticed calcified nodule in the earlier dilatations with the smaller balloon, which was not yielding at 2.5 balloon, and we had to circumvent this. And now we do a check shot, we find significant dissection in the mid segment, probably from our attempts of dilation with the 2.25 and 2.5 balloon. So we had OPN, but OPN we tried, didn't track. IVL was out of option because of financial constraints. So the option was still left with rota in a dissected calcified anomalous RCA with a non-coaxial guide. So we thought of doing the guide extension assisted rota. So we had a caravel in and a rota extra support wire in. We all understand that it's an old school thought that once you have a dissected coronary artery, rota can lead to progression of dissection or perforation. We all do rota in significantly dissected vessels, even if you just have to be slow and be less aggressive with rota. So we thought of looking at it. So we all understand understand that by literature, the only guide extension, 6 French guide extension which works with a 1.25 bar is a Guidezilla 6 French. The 6 French guide extension, only the Guidezilla from Boston, because Rota is from Boston, only 6 French Guidezilla from Boston allows good cooperation with the 1.25 bar. All 7 French guide extensions allow 1.25 and 1.5 bar. None of the guide extensions allow 1.75 bar. But this in vitro study also says guide extension for rotational atherectomy is off-label, and you should preferably use Dynaglide mode to deliver the bar inside a guide extension. So we take this guide extension in, so we have the 1.25 bar, but again we have another twist here. The guide extension, the 1.25 new Rota bar gets stuck in the proximal end of the 6 French Guidezilla. You can see in the ascending, the guide in the descending aorta, the Rota bar gets stuck in the guide extension, and we tried moving in with the Dynaglide 80,000 RPMs, but it just didn't get in. It actually got stuck in the Guidezilla, and in fact it damaged the bar. So the whole system was taken out. So we had now we didn't have any 7 French guide extension in the shelf at that time, so we thought of attempting a Rota with a non-coaxial guide. So we have a 7 French AL guide in, and we took a 1.5 bar. So we thought of dealing it with almost like a tortuous RCA. So the guide and RCA was in different planes. We had significant difficulty negotiating the ostium because of non-coaxiality. But finally, after some time with the Rota extra support wire, the 1.5 bar makes an abrupt sharp dive into the coronary. You can see on the left-hand frame, it makes an abrupt sharp drive getting into the vessel, and once the Rota bar was inside the vessel, rest of the things was quite easy. 1.5 bar ablated it well. We prepared the bed with a 160,000 RPMs, 1 minute of ablation. Since it was dissected, we went slow, gentle run with a TPA backup pacing and short duration of run. This is well described. Low speed rotational atherectomy will ensure that you can even do rotational atherectomy in significantly calcified, significantly dissected vessels. Now we put in the caravel, exchange the Rota extra support wire to Grand Slam, and post Rota 2.5 balloon without even a Guidezilla tracks down and opens up without a residual waste, and then we do a guide plus, we get a guide plus rail down over the balloon, and then with the guide extension we pass 2 drug-eluting stents at 2.75 into 38 distally and 328 proximally after balloon preparation with a 2.5 non-compliant balloon and 18 atmospheres, and fluoro-wise we find adequate stent expansion, and so we have the guide plus assisted. Then we subsequently optimize with a post dilatation of the full stent zone with a 3.25 non-compliant balloon at 20 atmospheres. And this is the final angiographic outcome. So angiographically we have good outcome. About 80 ml of contrast was used. He's on ticagrelor and aspirin for last 1 year, discharged on day 3, doing good on clinical follow-up, asymptomatic. So this is where we started off with an anomalous RCA which was quite calcified, balloon non-yielding, which was dissected after the initial balloon preparation, which was stented with good result. In fact, Rota was done with almost a 90-degree non-coaxial guide. So just 2 more slides. Just looking at back, we thought if the IVUS catheter didn't cross, we could if we had used upfront Rota, we would have saved the cost on at least those balloons which initially yielded up. Probably we went with the Dynaglide mode, but then somehow it got still stuck in the guide extension. And this has been described. Dr. A.B. Mehta has described anomalous right coronary artery from left side with a JL guide, but this was typically not from the high left sinus. So to conclude, when you think of Rota, it's always better do it upfront, do it early. Non-coaxial guides cannot always be compensated with a guide extension. Coaxiality of guide would obviously make Rota easy, so always try for coaxiality while you intubate the vessel with a type, whenever you're dealing with a type C lesion. We tried with the balloon different angles, but we just couldn't make it coaxial. Guide extension assisted Rota is useful for Rota in anomalous coronary arteries and whenever dealing with the distal calcified lesions, but always try to have a 7 French guide extension, which we didn't have in our shelf at that time because of the mismatch between the manufacturer's declaration and real inner ID. So sometimes even a Guidezilla 6 French might have a 1.25 bar stuck in, and it's always advisable to use a Dynaglide to advance bar and guide extension. Just for the beginners, a 6 French Guidezilla will take a 1.25 bar. 7 French guide extension will take 1.25 and 1.5 bar, and no guide extension will take a 1.75 bar. So, thank you.
Thank you, Dr. Arun. An excellent case, very well handled. Yeah, you said the burr, when you are trying to get into the guide extension, it damaged the guide extension, or the burr got damaged?
Actually, we were trying to introduce with the Dynaglide. It got stuck in the proximal part of the guide extension, and then we just couldn't move in either side. And though we had to take the guide extension and the burr, everything together, and so both the burr as well as the guide extension was damaged.
Any questions?
As usual, beautiful case, Arun. Regarding the guide extension catheter, in these sort of anomalous vessel, when you compare this Guidezilla versus you used Guidezilla or
Guidezilla, first Guidezilla.
Yeah. Compared to Guidezilla, the Guide Plus
Yes.
from the Nipro, I hope you also have the experience. The trackability of the Nipro one, the Guide Plus, is much more better compared to this one. So first point, so getting into these sort of anomalous RC, even without having a balloon anchoring, it will be much easier with that. But then the problem with all these 6 French compatible guide extension catheter, it will never take up a rota 1.25 bar also, because even in our experience, even though the literature says Guidezilla can take up a 1.25 bar, it always gets stuck at that particular shoulder of the, so it's advisable that whenever we want to have a rota, it's better to go with a 7. That's our experience also. Like
Guide Plus is our workhorse guide extension now for all these things,
because of the trackability.
Yeah, it's easily trackable, but only thing is the tip is so soft, the reusability becomes less. But definitely in this cases, since we ordered rota, we went with the Boston recommendation, but it didn't work.
You could have probably gone with the 7 French.
We didn't have a 7
anyway,
French.
you were you went through the groin.
Regarding the 6 French Guidezilla, even when you try to do it, get the burr into that particular guide extension catheter on the table, not inside the patient's body, even when you try it outside the body, it's extremely difficult for it to go inside.
We learned it in the hard way. We took it this, and we didn't have a 7 French guide extension, and Guide Plus doesn't come in 7 French also. It comes only in 6 French. So only 7 French Guidezilla and Guideliner is there. We didn't have it on the shelf. Yeah. Thank you.
Thank you, Arun. Very interesting case. I think next, Dr. Deepak Davidson is going to show us a case of a rocky LAD and an RCA in a post-CABG scenario. Any other speakers have come? Those are in the one.
Can I have the slides, please? Well, good morning to all of you. At the outset, thank the organizer for the opportunity given. Well, this is the case history of a 70-year-old doctor. He had undergone bypass surgery 20 years ago. Now he's got recurrent acute coronary syndrome, recurrent episodes of angina. He was admitted in a nearby hospital where he was taken up for an angiographic evaluation. You could see that the circumflex is totally occluded, the left anti-descending artery is totally occluded, and the right coronary angiogram, you could see that there is a diffusely calcified distal critical stenosis. And in the second image, you can see that the vein graft to the LAD is flowing well, and you could also see that there is a critical stenosis in the left anti-descending artery beyond the vein graft anastomosis. Well, they attempted to open up the right coronary artery. They tried crossing a balloon. It was not possible. They wanted to do a rotablator, but then again the microcatheter wouldn't go through. They tried with an OTW balloon. The OTW balloon also wouldn't get across the lesion, so they didn't get a rotafloppy distally. So the patient was referred to us for a possible lacing of the uncrossable distal RCA lesion. So that is how he landed up with us. So our strategy was, we felt that the left anti-descending artery was going to be much easier to be tackled. There is only a short lesion with little bit of calcification. So we told them that this is going to be a much easier procedure for the left system. So we start off with the left system, we'll finish it within half an hour, then move on to the difficult right coronary artery. So that was the thought process like. So the strategy for the right coronary artery is, because it was an uncrossable lesion in the right coronary artery, we thought that we'll go ahead with lacing and go across the lesion, then exchange it for rotafloppy, prepare it with rotablation, then balloon dilatation, and then IVUS guided stenting. So that was the strategy when we started off the procedure. We went through the femoral approach. That was a 7 French guide catheter. That's a good supportive guide catheter. That's a short Amplatz left catheter, and on the vein graft, we tried to, our plan was to get across the lesion with a fielder FC wire, get the microcatheter across, then exchange it for a rotafloppy. You could see in the second frame that there are 2 areas of calcification. The pink one, it shows the anastomosis. There is a small amount of calcium there. The distal one is a chunk of calcification in the LAD, but then we expected that it's going to be very easy. So we tried to wire with a fielder FC wire. We wired it, but then the microcatheter, that's a caravel catheter, wouldn't go across. So it got stuck at the proximal lesion. That's that. The anastomotic site, it got stuck. We switched over to a fine cross catheter. The fine cross catheter also wouldn't go across. So we removed the fielder FC wire, tried to wire with the rotafloppy wire. You could see that the rotafloppy wire was not going distally, it was going retrogradally back into proximal LAD, and we found out the reason for that was that the anastomotic site in this scene, in the frozen image, you can see that there is a shelf-like projection there. That was the reason why the wire was going back into the LED rather than going forward. After changing the curve of the rotafloppy, we were able to wire it. It went down into the left angiodescending artery. Then we started off with an 1.5 millimeter burr. It was at 180,000 RPM. You could see that it's getting stuck at the initial calcium. There are two areas of calcium. It got stuck at the initial calcium. In the second image, you could see that we went up to 200,000 RPM. It crossed the first calcified area. Then in the third image, you can see that at 220,000 RPM, we were not able to get across the distal calcified chunk of that calcified segment. So we made two modifications. We decided that we'll downsize to an 1.25 burr, and the second thing was we decided that we'll go with a guide extension catheter. That is a guide extension catheter, 7 French comparable guide extension catheter. It was actually difficult for us to get the 1.25 burr even through the 7 French guide extension catheter because of all these tortuosities and the angulation of the vein graft over there. But we were able to get it down there with the help of an activated burr advancement, that's with the help of a dynamo. 125 burr at 200,000 RPM. You could see that it was not crossing. We went up to 220,000 RPM. You can see in the second image that we were trying to force it across that particular area, hoping that in case it got stuck there, we'll have a guide extension catheter. With the help of that, we'll pull it out. Then it was again not crossing. It was almost 3 minutes of burr time. So ultimately, we switched over to a New York burr. We had to take a new burr. It was an 1.25, and this time with the help of a judicious push also we were able to get across the LED. So you could see here that we were trying to push it bit hard against that with a power backup support from the telescope. That's a 7 French guide extension catheter, and it crossed the lesion. Once it crossed the lesion, things were more or less easier. We dilated it. We did IVUS evaluation. There was napkin ring calcification, which was dilated, stented, and we were able to achieve a good result. Took almost 2 hours. We thought that the procedure would be over in half an hour time. We could switch over to the right coronary artery, but then it took 2 hours. We wanted to stage the LED, but then he, being a doctor, he told that I'll be comfortable lying like this for another 2 more hours. Please continue with the right coronary artery. Even though we didn't want to do that, but then we were forced to do the right coronary artery intervention at that point of time. So again, cannulated the right coronary artery with a short Amplatz catheter with a good backup support, and then we didn't want to waste time, so we wired it and went ahead with lacing. That was a 0.9 millimeter laser catheter. It didn't go across. Then we switched over to a backup support with the help of guide extension catheter. That's a guide plus catheter. Again the lacing catheter wouldn't go across. Then we did contrast lacing. With contrast lacing, we were able to get the lacing catheter a little bit forward, but then it didn't cross the lesion. But then we were able to wire it and do a rotablation. 1.25 millimeter burr. Finally, it crossed at 200,000 RPM. Then 1.5 millimeter burr again at 200,000 RPM. It went across. Then we did IVUS evaluation. You can see so much of reverberation, so much of polishing done to that napkin ring calcification. Then we went ahead with balloon dilatation. Took a couple of long stents, one distally and one proximally, because IVUS revealed that the entire vessel was diffusely diseased, so had to take 2 long stents. Then we started post-dilatation. At post-dilatation, we found out that at that particular area, more proximally inside the right coronary artery, we were not able to dilated. Then we went ahead with an OPN balloon. In the first image, if you concentrate on the first image, you can see that at 35 atmosphere, it opens up the vessel very clearly. And then we came back proximally. Again, proximally, we were not able to dilate it. So you could see that this was a flow inside the vessel. Proximally, we were not able to dilate it properly. By this time, patient had some hypotension. We looked whether there was retroperitoneal hematoma. Things were better. Things were okay. So we continued with the procedure. Then we again did an IVUS evaluation. Again found out that the minimal luminal areas was not good for that. So again, we switched over to an IVL catheter, 3.5 IVL, 80 pulses exactly at that particular area. We were not able to totally open it up, but then it was almost 3.5 hours into the procedure. Patient has started developing hypotension. So we thought that probably we should stop at that point of time, because we exhausted whatever devices we had in a cath lab for managing this right coronary artery. And we ended up having a TIMI3 flow inside the right coronary artery with a little bit of under expansion and a good collateral flow into the circumflex artery. So that was the final result, and the IVUS evaluation, we made out that at that particular area, the minimal luminal area was 5 point something, but then proximally it was 9 plus. So dear friends, the take-home message, the learning points for me, all these post-ABG patients, they are extremely difficult to manage. We attempted managing this particular patient with multiple device signage helped us in achieving reasonable results. Short Amplatz left catheter, good backup support, rota with 1.5 millimeter and LED did not cross at 220,000 2000 RPM, downsized the rota to 1.25 with a power backup with the telescope 7 French guide extension catheter. I was for optimization. Right coronary uncrossable was managed with lacing with contrast, then rotablation with 1.25 and 1.5 bar, then non-compliant balloon, angioscalp stent and expansion was managed with OPN and intravascular lithotripsy. Still had to settle down with a little bit of under expansion, but we were happy at the end of the day that we ended up with a safe procedure and a TME3 flow, and the patient did well he's doing well for the last 3 months. Thank you so much.
Great, Deepak. You've handled, it was really a rocky case. Needed rocky Deepak only to handle this. I just want to know why you chose laser as the first strategy rather than directly going into the rota in the RCA, because
Yes.
it was an uncrossable
Yes, sir.
balloon
If
uncrossable
we
lesion.
didn't have laser, probably we would have tried with a microcatheter. In the other center, the microcatheter as well as an OTW balloon didn't cross the lesion, so they were not able to get a. It was easy for them to wire with a Fielder FC wire, but then none of the microcatheter or OTW balloon crossed for them to exchange with the rota floppy. So we'll have to do a primary wiring with the rota floppy.
Rota, okay.
We didn't want to take.
That risk,
We didn't want to have more of time because lacing was much more easier. It takes only less than 5 minutes, so we decided that rather than keep on trying, we'll go stepwise
Okay.
as far as early as possible, because it's almost 2 hours into the procedure with the LED, which was totally unexpected.
With this case, you have literally given an algorithm for an calcific lesion management, especially the RCA. All the techniques used synergistically.
Yes.
The laser, then the
Yes,
rota, then the under deployment of the stent treated with IVL. All steps have been highlighted. Any questions? Any clarifications? Yeah.
Do you think orbital atherectomy would have allowed you to ablate that area much better than the rotablation, and probably might have allowed to expand it?
True, sir. Definitely that was an option. We didn't want to go with an 1.75 bar because we felt that we had a proper dilatation of the distal RC with a 3 mm non-compliant balloon and angioscalp. We tried with both these things. Orbital atherectomy, we have very little experience. We've just had 7 or 8 cases done. We felt that in a very difficult case, orbital also, it takes very long time and procedure time is going to be extremely high with an orbital atherectomy when you have a difficult lesion and a diffuse lesion. So we are always happy with rota in a diffusely calcified lesion, because once you're across it, then you're done with that.
Excellent case. Just when you had IVL when you are already planning IVL, does the sequence of once you do an IVL, post IVL OPN makes things better, or pre IVL OPN things better? Because sometimes they say with the IVL fractures, after that you go with high pressures, the stent might still be easier to open up. Then one more thing, like regarding orbital, when balloon is not crossable, orbital never go, because it's a side ablating thing. A front ablating thing is required whenever there is a balloon non-crossable. So anyway, rota is good. If you wedge the microcatheter down, like you would obviously be doing all the time, and then you can pass a rota extra support and probably do. But you had laser, or you had all the gadgets, so you have the luxury of doing all this.
Regarding the orbital or regarding the IVL, to start off, again, cost was always a concern, because we know that we are going to take a lot of gadgets, at least 2 rota burrs. We had to ultimately take 3 rota burrs, new burrs. So cost was always a concern. So we always reserve IVL for the last option, because we feel that OPN does as good as IVL, and the cost is too less. Only thing is, while doing every time you increase the OPN pressures, your blood pressure also keeps going up compared to IVL. That's.
Hi Deepak, wonderful.
Sir,
case.
your experience with orbital.
Actually, regarding orbital, it is also useful for crossable lesions, but we should not use for such a dense calcium. It spins. It's a centripetal movement. When the centripetal movement is very rota, centrifugal, it can probe. It can go. That's the reason the first choice for uncrossable lesion only rota. But if it not that much calcium is there, it can spin and it can go. But if you see the calcium, it's too thick. Even that LED also very tight. In such cases, we should not try the orbital, because what happens, it spins just before entry and it can create a big dissection and it can cause perforation. Once you cross, if you want Like a second case also.
Polishing.
Yeah, first the second case also, once you did the rota, if you want, after rota you can use the orbital for better deep
I think that was
coupling
sir
and-
asked for further volume reduction of the calcium.
You
Could
can.
you have used orbital?
Yeah, the orbital. But you should not use it to less than 3 mm diameter vessel. If less than 3 mm, you should use only 80,000. Never use 1,20,000 when you are using the orbital. 80,000, 1 mm per second. That's one.
Sridhar,
And
I think rota is centripetal, orbital is centrifugal.
that
You just said the
centripetal means
reverse.
along the periphery.
Yeah, that
Yeah,
orbital
yeah,
is centrifugal, yeah.
So that is the advantage. So and rotatripsy, it's a classic case. Just now he mentioned, it alters the compliance. After that, open NC works well. We did many rotas, post rota, calcium thickness on OCT 1.2 mm. Once you use rota, most of the time it heals because you gave already rota, and after that IVL, it block modification. That time open NC can work. But anyhow, you got
Thank
5,
you.
very good.
Thank
Even I was study showed 5.5, excellent result. If that even 9, this doesn't matter, but 5.5 definitely very good area.
Thank you so much.
Thank you. I think there are no more, are there any speakers who have come late? No. I think thank you all. It was a very interesting session. Thank you, Deepak.
The next session is STEMI and STEMI Shock, 6 plus 2 minutes. The chat.
One more is there. Who's? Yeah, Dr. Vishal Chavan, last case. Rotational atherectomy in a case
Good
of
morning, all.
calcified LED. Yeah.
I am going to present a case of rotational atherectomy in a case of calcified LED disease with the adjunct of newer generation OCT 1.0 Ultron 1.0 software. I am going to present a case of 64-year male who was a non-smoker, hypertensive, non-diabetic, present with acute coronary syndrome. On presentation, he was vitally stable, and CVS examination was normal. ECG was showing valence type B pattern, prop was negative, string echo was done and was showing EF of 60%. There was no RWM, TRAS MR, TRAS TR. Diagnosed as unstable angina and posted for coronary angiogram. This was the ECG of the patient. As you can see, there are precordial T wave inversion in this was the angiogram. Angiogram was showing that there was 90% lesion in the mid LAD and 70 to 80% lesion in the distal one. This was the angiogram. This epic renal view is showing that there is nearly 90% lesion. RC was bit normal. We had tried to do pre-PCI OCT, but the catheter, which was Dragonfly Optis, it was unable to pass the very heavily calcified lesion. That's why the pre-PCI OCT was abandoned, and the patient was proceeded for rotablation as the catheter was unable to pass. We did rotablation. The access was femoral access with 7 French sheath. Guide was XView 3.5. We done with run through wire. That we did with 1.75 mm burr with 1.6 lakhs RPM, and there were 3 runs of rotablation, 20 seconds each. And post rotablation, PTC with 1 drug eluting stand was done with OSIO 3/40 with 10 atmosphere, and post dilation was done with NC 3/12 with 16 atmosphere for 10 seconds. This was the stand which was expanded, and post PCI OCT run was taken, and it was showing that the stand was well opposed and the expansion was good. This was done with OCT Ultron 1.0 software. And this was the final angiographic result post stand implantation. It was showing TIMI-3 flow, and there was no proximal or distal dissection. And this is the algorithm for calcium management. Pre-PCI, we are supposed to do OCT, and uh, if there is calcium R greater than 180 degree, it scores 2 points. Thickness greater than 0.5 mm, it scores 1 point, and length greater than 5 mm, it scores 1 point. And if the balloon is uncrossable, then we have only two options: rota or orbital atherectomy. If balloon crossable lesions, we can do IVL, or if there is a mild to moderate calcium, we can try scoring balloon, NSA balloon, and OPN balloon. And after post calcium modification, we are supposed to do OCT imaging, and calcium is well fractured, we can proceed with the stenting. Take home points. Lesion preparation before stenting remains essential component of PTCA, especially calcified lesion. Both IVUS and OCT provides important insight in the coronary calcium morphology, but OCT can evaluate calcium more accurately. There are many devices in the armamentarium, including open balloons, cutting balloons, scoring balloons, IVL, rotablation, orbital atherectomy, and ELCA. The systemic use of intracoronary imaging is key to improve the understanding about the lesion morphology and provide guidance about choice of calcium modification strategy, and may promote improved technical success and patient safety.
Thank you, Dr. Vishal, for an interesting case with the new OCT system. Any questions?
It's a very interesting case.
Yes.
The lesion itself was a very critical stenosis.
Yes.
So in these sort of situations, when we want to do an imaging, we always try to do imaging after either a small balloon dilatation, or if you have heavy calcification, we try to do rota, so that you have an opening of the lumen, so that the OCT catheter could go in easily.
Yes.
And then even you need to have a distal contrast flow, isn't it, so that you can have a good imaging done. So here what has happened was, because it was a very critical stenosis, you couldn't get the OCT catheter across, and then again the imaging was not possible to start with. So in these sort of difficult situations, we always try to modify the plaque partly, then do the OCT evaluation.
The OCT catheter was passed. As the catheter was unable to pass, patient started developing chest pain, and ST was elevating. That's why we had proceeded for rota.
True. That's very true. So in this critical lesion, what I meant was either a balloon dilatation or a rota followed by further evaluation of the morphology of the lesion with OCT would be preferable.
Yes. Okay. Thank you.
We'll close the session. Thank you, Dr. Vishal.
The next session is STEMI and STEMI Shock, 6+2 minutes. The chairpersons for this case presentation session 49 are Jaspal Arneja, J.R. Kane, Animesh Mishra. And the discussants for this case presentation session 49 are Hari Om Tyagi, Amjad Syed, Pritesh Parekh.
So let's get going, because we are already, I think, a little bit ahead of 9 o'clock. And let me invite my friend, Dr. Thomas Alexander, for the first talk. He's deeply involved in STEMI management and the STEMI protocols and the hub and spoke models and whatnot. So he's the right person to give us this talk. Please go ahead, sir.
Thank you. I have 8 minutes, so I will go through 8 different points. This is a paper that we published in Circulation Cardiovascular Interventions. This was during the COVID time. So this really looked at the equipoise between fibrinolysis and primary PCI, and clearly shows that if there is going to be a delay of greater than 120 minutes to doing a PCI, then one should thrombolyze first and then go the pharmacoinvasive route. So here are the 8 points that I will quickly touch upon, 8 slides. When should you think of pharmacoinvasive treatment? And I think this is very clear in a country like ours. First, of course, there should be no contraindication to fibrinolytic therapy. Early onset of symptoms, the earlier the better. If you do it within 3 hours is the best time, if you can do it within the first hour. Especially if you have borderline diagnosis of an ACS, it might be sensible to take the patient out to the cath lab rather than doing a pharmacoinvasive at that point. But if it's a straightforward STEMI, you could do that. And if a patient presents to a non-PCI hospital, certainly that is the time to think of a pharmacoinvasive therapy. The question then is pharmacoinvasive therapy better than standalone fibrinolysis? And this is a huge network meta-analysis. Again, we were involved in this, Ajit, Brahmaji, Dharam Kumbani, and we took all the studies, thrombolytic therapy versus facilitated PCI. There were 3 studies, 7 facilitated PCI versus primary PCI, 14 studies that looked at thrombolytic therapy versus primary PCI, and 5 studies that looked at primary PCI versus pharmacoinvasive. And this is the results. If you took the reference as fibrinolytic therapy and looked at primary PCI, clearly primary PCI is superior in terms of mortality, in terms of reinfarction, in terms of stroke. So clearly primary PCI is the way to go. If you were to compare fibrinolytic with pharmacoinvasive, let's leave the facilitated out of that, you can see that at least in terms of reinfarction, pharmacoinvasive is certainly superior. And if you were to look at estimate the probability of maximum risk, and you looked at primary PCI as the standard, then fibrinolytic therapy, there was a 69% increased chance of mortality, 99% increased chance of reinfarction and of stroke. But when you looked at pharmacoinvasive, mortality is higher than in primary PCI, but if you looked at reinfarction, that's where the real benefit is. Can streptokinase, this is the other common question that is asked, can streptokinase be used as the lytic in a pharmacoinvasive? And this is from the Tamil Nadu STEMI program. You will see that in 96% of the patients, we used streptokinase in this study. And this was published in the American Journal of Cardiovascular Drugs. Total of 1,215 patients, and we did a propensity analysis. So we took about 400 streptokinase PCI pharmacoinvasive group, 815 primary PCI, and we looked at the multivariable models adjusted for the various known risk factors, safety outcomes, and these are the results. If you looked at streptokinase pharmacoinvasive 1 month, and you looked at you looked at mortality, 2 versus 2.1%, 1 year 8.5 versus 8.1%. So clearly, streptokinase can be used in the pharmacoinvasive strategy. What about the optimal time? Again, this is a question that is often asked. Streptokinase being a non-fibrin specific lytic, should one delay the treatment? And this is the data. If you looked at the various trials, STEAM, SEPE-MI, Early Mayo, the Ottawa registry and the CAMID registry, you can see that it's usually within the first few hours. But if you look at the TA and STEMI program, and that's the only pharmacoinvasive data that you have with the use of streptokinase, we did pharmacoinvasive therapy at 17 hours with no increase in bleeding risk. So maybe this is more, again, not clearly a double-blind study, but we've used a strategy using a little bit of what we would call common sense to understand that if it was a successful thrombolysis, it might make sense, especially when you're using streptokinase, to delay the pharmacoinvasive therapy to the latter part of the window period. The lytic dose in elderly in pharmacoinvasive, and this data comes from the STREAM study. STREAM, if you recollect, was within a patient presenting within 3 hours, and when you expected a delay of more than 1 hour to take a patient to the cath lab. Now, just remember, in the STREAM study, in the elderly, after 1/5 randomization, the dose of tenecteplase was reduced to half dose in the elderly subject because there were increased intracerebral bleeds. Now, the STREAM after that, and then there is the stream 2, which has just been published, which looked at above 60 years and used half-dose tenecteplase. And these are the results. Both studies are comparable. If you look at stream 1, in terms of the composite endpoints as compared with primary PCI, stream 1 was 12.4 versus 14.3. In stream 2, this is the elderly subset with half-dose tenecteplase, 12.8 versus 13.3. So clearly in the elderly, it makes sense to use half-dose thrombolytic, maybe even looking at 60 plus, reduced to half plus in terms of, there was a small signal of increased bleed even with this half dose, but I think if you take the stream 1 data, once the dose was reduced in the elderly population, the bleeding risk clearly came down, and therefore it makes sense in the elderly to reduce the dose. How else can you reduce the bleeding risk? And this is again from the TN STEMI program, where about 80% were radial patients, and maybe using a radial procedure, using half dose in the elderly would reduce your bleeding risk in this group. What about the use of DAPT in the pharmacoinvasive group? So these are the patients who've been thrombolyzed outside, utilize clopidogrel plus a lytic. When they come to the cath lab, what should be your strategy? And this is data from the TREAT study, where there was an addition of ticagrelor in these patients who came to the cath lab. And this was at a mean time of 11 hours, and what you can see is that in terms of safety, there was no difference in safety by adding ticagrelor in this patient. In terms of efficacy, the study was underpowered and therefore cannot say that. But again, we just pulled out data from our data, and if you look at the lower table there, clopidogrel that was used in the pharmacoinvasive group and the newer antiplatelets, either ticagrelor or prasugrel. And if you look at mortality, 1 month mortality is 3.1% versus 5%. 1 year, 2 year, 1 month that is. 1 year mortality is 4.3 versus 10.2, and 2 year is 6.4 versus 13%. So in terms of efficacy, clearly if you were to use the newer antiplatelet agents, rarely do we use prasugrel these days, but ticagrelor, if you were to add on ticagrelor, there is safety data from the TREAT study, and there is efficacy data from the TN STEMI program. And finally, does setting up a system improve the results? And this is, again, from the TN STEMI program. By setting up a system of care, we were able to reduce the time to first medical contact, time to ECG, lysis to angiogram, total ischemia time, and this translated into better TIMI flows and reduced mortality. And finally, this is an editorial that Ajit and I have just written in circulation, will be out next month. Timely primary PCI has been shown to be the most effective and safe reperfusion strategy. The totality of data from stream 2 supports the stream 1 and stream 2 supports the utility of pharmacoinvasive. There are lingering concerns about ICH and failed reperfusion, but in LMICs where we practice, I think this is the best strategy as we transition from no reperfusion to standalone fibrinolysis to pharmacoinvasive strategy. And ultimately, as our cath labs increase, as we are able to access and move our patients to primary PCI in our STEMI networks. Thank you.
Thank you very much. Nice lecture. I have personally a question to you. Most of our now emergency departments load with ticagrelor because thinking that the patient will accept primary PCI, and then they say they can't afford it. So how safe is thrombolysis in this type of patients?
So we have no data regarding that, and again, I think this might be an area where there is a study just coming up on the use of ticagrelor with a thrombolytic, but until then, I think it's probably a risky strategy, and I think I would rather tell the emergency department load with clopidogrel. I feel very safe adding on ticagrelor to that if they go straight to the cath lab.
Yeah. In fact, we tell the department to load only 300 milligram of clopidogrel, not even 600 milligram, and then subsequently we go to that. Yeah.
Morning, sir. First of all, your role for STEMI is invaluable, sir. Wonderful job. You are guiding many Indian doctors regarding STEMI aspect. Another thing is, sir, observations, 30% received prasugrel compared to ticagrelor. It's 9%. Is it because of the scheme? Why, sir? The majority of the patients are receiving prasugrel versus ticagrelor.
In the
In the observation, 38%.
in our TN STEMI program, yes,
STEMI
this was a period in time where prasugrel was the dominant medication and ticagrelor had just come into the market.
Okay, then.
So this is a slightly older data, but today we don't use prasugrel in that setting.
Yeah, thanks very much. We'll move on. Yes, please, go ahead.
Would this stream, etc., was when the admission was within 3 hours of ischemic time? Would pharmacoinvasive therapy be advisable if the ischemic time is more, patient comes after 6 hours, for example?
So we are open to the full 12 hours period that we say that you can use thrombolysis. But this is specifically speaking about the stream and the stream 2 data, which was within the 3 hours of chest pain onset.
Thank you very much. So let's move on because we are short of time. ACS lights off. Ahmed Nada, is he there? Dr. Nada is not here. So we move on to the next, a curious case of dual LED presenting with STEMI. Sushant. Sushant is there? Yeah, please come. Good for you. You'll get a little more time so we can discuss.
Respected chairpersons and discussants, I wish you all a very good morning. And today I'll be presenting a case about type 4 dual LED, which presented to our center, which is the National Cardiac Center in Nepal. So this case is of a 74-year-old male. He is a smoker and a diabetic, but not on other medications. And he presented to us with complaints of chest discomfort of about 10 hours duration. ECG showed a segment elevation in the anterior lids. No significant findings on PE. His vitals were stable. A screening echo done at the ER showed hypokinesia of mid and basal anterior walls, EF of about 45%. And with the intention of primary angioplasty, a patient was taken to the cath lab. So left system angiography was done through the femoral root, which showed the LCX. As you can see here, it was a non-significant change in LCX. And the LED proper, which arose from the left main, was comparatively of smallest caliber. It was giving off septal and diagonal branches, but it seemed to have just halted in its course after about the proximal third. As you can see here, it seems to have just halted in its course. Another views confirm the findings. As you can see here, the LED was quite small in caliber, and after about the proximal third, it seemed to have just stopped in its course. It was giving off septal and diagonal branches, but there was no continuation of the main LED throughout the left of the heart. So it could possibly have been a total occlusion, but it didn't look like a thrombotic occlusion here. So probably there might be some other pathologies that would be there. So a right system angiography was done, which showed the right coronary was dominant with some lesions throughout. And as you can see here, there was another vessel that arose from the proximal part of the RCA. And a better view confirmed that finding. As you can see, there was a big vessel which arose from the proximal part of the RCA. And this vessel traversed through to the anterior intraventricular septum, and it continues its way down towards the apex. It was also giving off septal and diagonal branches. So indeed, this was a second LED that arose from the proximal RCA. And as you can observe here, there is a occlusion at the third diagonal branch, as you can see here, a thrombotic occlusion. Don't know if you could see this. Yeah. Anyways, so there was a total occlusion of one of the diagonal branches. So indeed, this was probably the culprit artery that was and the artery came out from the second LED that arose from the proximal RCA. This was indeed a type 4 variety of a dual LED, and dual LEDs are quite rare. They account for about 1% of all patients with anomalies, and anomalies are about in 1% of patients undergoing angiogram. So dual LED, just for review, there are 4 types of dual LED. Types 1, 2 and 3 is where both the long LED and the short LED arise from the LED proper. In type 1, the long LED travels in the left side of the intraventricular septum. In type 2, the long LED travels along the right side of the innervated septum. In type 3 the long LED travels intramyocardially. And in type 4, as you can see here, in our case, in our patient, it arises from the proximal part of the RCA. It travels through to the left side, and it continues its way down towards the apex of the heart. This classification was proposed by Spindler-Franco in 1983, and that's what we still follow these days. So this is from the original paper by Spindler-Franco, and as you can see here, they describe the same thing. The long LED arising from the proximal part of the RCA. So I'll probably be raising some eyebrows here, but yes, at that time, patient was managed conservatively. If we look at it from hindsight, yes, I do believe that some intervention should have been done, but that's how it was, and patient was managed conservatively. And during the hospital stay, we also did a CT scan, which confirmed the findings of a dual LED. And further evaluation, the second LED that arose from the RCA traveled between the aorta and the RVOT. So it was a malignant course, and CABG was indicated, but the patient denied any further intervention. But he did well. He was symptom free. He got discharged on his fourth hospital day. He still has a good functional status and is under follow-up. And his EF had slightly improved. So yes, patient, although was managed conservatively, he did okay. So this is a very rare pattern of dual LED, and awareness of this pattern is very important, because it's even more important in planning revascularization, especially during surgery, because incorrectly placed arteriotomy site will lead to severe consequences. Also on the angiogram, this can easily lead to confusion. A short LED can be misdiagnosed as a total occlusion, and a long LED can be misdiagnosed as a big conus branch. And usually in these kind of anomalies, further anatomic evaluation, especially through CT scan, is required for further risk stratification and aiding in treatment decisions. As in our case, although CABG was indicated, but the patient declined, but still for risk stratification, usually further evaluation is required. Thank you.
Good, wonderful presentation. Very beautifully you showed anomalous LED coming from the right, but really very good case. Thank you.
You should publish it. The only one comment I have is, whenever I face with similar situations where you cannot make out whether the LED is totally occluded or there is something else going on or it is a short, I generally prefer on-table thrombolysis, because it is safe, because you have an MI definitely. So you thrombolize, and many times you feel if you give intracoronary also, you find the artery opens up, or you bring the patient on the next day or after some hours. That helps in some cases, but your case is unusual and very interesting. Thank you very much.
Thank you, sir.
Yes, sir.
In this case, it was the diagonal probably which was the culprit.
Probably,
right?
yes.
What would have happened if the LED would have been the culprit? If it would have been, blocked in the proximal part. If it was an anomalous LED rising from RCA and it's blocked in the proximal part, and we open it up. The patient in this case, fortunate enough, it was just a diagonal left on the medical management, and later on it proved to be having a malignant course. So if it's a proximal LED occluded, and we could have just thought that it's a short LED, it's a dominant LED, and patient probably would not have been revascularized at that time if it was occluded in the proximal part of the anomalous LED. Or if we would have revascularized, it would have been a double whammy because it's already having a malignant course. What would have happened at that time? How would you do it?
No, only clinically if it is not calling, that's what they suspected. The proximal LED appeared very small is, so based upon that, always check the right. The right already they found the LED is flowing very well. So engaging the right is not a big issue.
No, I'm sorry, I was...
No, LED...
No, we didn't understand you.
Yeah, so the point is that here the LED, the native LED was small, the other anomalous LED was large enough, and the culprit was diagonal. What if the culprit would have been an anomalous LED which was arising from the RCA in the proximal part?
Okay, I understood. Now I understood. So what would have happened?
Yes.
You would have opened it.
Opened it. The primary angiogram.
You may have avoided a stent if you think this is anomalous origin. Just open it, give the patient the benefit of an open artery, and subsequently do a CT. The RCA angio, this is just in addition, not to answer your question, is always important when you don't see proper LED, because you will see nice collateral sometimes, and then you will know that this is LED is there. So RCA angio is very important whenever you have doubt. So there's no
They
doubt.
would have
about
done
it.
LED
Yeah.
then and there, but LED is flowing very well. That's the reason they have not done.
That's
Yeah.
okay.
If
Yeah.
suddenly closes, you have to do it.
Or
Chalo.
probably we could have mistaken it as a smaller branch, and probably we just thought that LED.
Yes,
is
everything
Yeah.
is
So
possible.
that's possible. That's
Thank you.
possible.
We'll go to the next. Yeah, your points are well taken. Who's the next person? Next one, does he know? Dr. Hamid Abdul Sada. Yes. Please come, sir. Yeah. Unusual case of STEMI. Dr. Hamid Abdul Sada.
I am a consultant cardiologist from Iraq, in the south of, from Basra in the south of Iraq. And I have a case interesting I want to show you. I have the honor to be here in India, and this is my first visit to India. And it is a great pleasure to participate with my simple, humble case with you.
Welcome, sir.
So, yes. A 56 years old man presented to our cardiology service with intense central chest pain as an elevation myocardial infarction. His ECG shows anterior myocardial infarction. We proceed directly to the coronary angiography, which showed an ectatic aneurysmal left anterior descending coronary artery with heavy thrombus burden with TIMI flow 0. Before that, echo study shows septal and apical wall hypokinesia with ejection fraction in the range of 40 to 50. The patient definitely have elevated serum troponin, no significant previous medical illness, neither a smoker or a drinker or a drug addict. And this is clearly the ST changes seen in anterior lead with other changes involving also the inferior. And this is the coronary angio, shows how much the area of ectasia with very slow flow, distally heavy thrombus burden. I was hesitated to choose the best modality to manage that patient. But lastly, I go to give a thrombolytic therapy, and the available was TBA. I give it, this is the right angio. I had give intracoronary ectylase, 10 cc intracoronary directly, then 1 cc every 1 minute for 20 minutes. His coronary flow was established. The chest pain is improved gradually, and the patient was stabilized and discharged after 2 days. You see, this is after giving thrombolytic intracoronary. The point is, I had to search for the cause. What astonished me is that the patient have no risk factor, no diabetic, no hypertension, no, lipid abnormalities was good, including lipoprotein A. Screen for VDR was negative as well, homocysteine, COVID, connective tissue disease. The only thing which I found after screening for thrombophilia, I found that there is a minor genetic abnormality, in part a rare mutation of the 4 gene polymorphism. It should be 4x4, and by the genetic it is 4x5. The summary of this genetic mutation, it favors an increased level of plasminogen activator inhibitor transcription and little impaired in the fibrinolysis. So it can lead to less thrombophilia. What other problem is that to use what further after giving thrombolytic therapy? There is no full agreement about the treatment. I keep the patient on double antiplatelet therapy, including in addition to novel oral anticoagulation for 1 month, and then I keep the patient on aspirin and rivaroxaban 20 milligram. The patient seen repeatedly and was asymptomatic. His ejection fraction improved to 53, and this is after 6 months of follow-up and was clinically stable. The home message is that coronary ectasia, we know it is about 1.5 the diameter, prevalence in the general population unknown, but it is documented to be 1.3 of the coronary angio, and it is a relatively rare disorder. Can be complicated by spontaneous thrombosis and present with acute myocardial ischemia. You should screen for a middle-aged patient for thrombophilia causes if you don't identify a clear risk factor. The optimal management is not well established till now, but should be individualized according to the patient character and whether the aneurysm is the culprit or the incidental finding. And the last message that for acute myocardial infarction, stent is not the only option. Thank you.
Yeah, very good case, very nice picture. It's looking like anaconda. It's a very, very huge ectasia and a massive thrombosis. But you managed it, intracoronary thrombotherapy, everything. Very nice, nicely treated. Thank you, Anand.
Yeah, the other thing is we are still in dark how to treat these patients on a long-term basis. Many of us give only DAPT for lifelong because we are more comfortable with DAPT. Now, introduction of a NOAC, people are using NOAC now. Which NOAC, what dose, how long? But I feel generally they require lifelong treatment, whatever you do. Thank you. Yes, sir. Anything? Yeah.
I had 2 patients like that.
Okay.
With repeat MI after 2 years again in a different territory. Then I have put him on NOAC for life because after the second MI in 2 patients, very ectatic arteries, twice done plasty outside and again an MI because of the ectasia.
Yes, you see that there is 2 problems. The patient have thrombophilia and the anatomy is abnormal. So for that reason, I'm afraid from getting second or third MI. So I keep him on novel oral anticoagulation, possibly for life.
Absolutely.
Usually because the massive dilatation, there will be stasis. The flow velocity comes down. So when it stasis, they're prone for thrombus. These are prone. Ectatic patients are prone for, particularly if they smoke. They're thrombogenic more.
We also encounter same. This repeated MI in same vessel, same places with dual antiplatelet. Now we are using oral anticoagulants. After that, the incidence is coming down.
Absolutely, yeah. So we'll move on. Next, Dr. Pranay Gore, nailing the stent thrombosis in acute MI.
So very good morning to one and all, and my regards to my boss sitting on the dais. So this is a 51-year-old male who comes to us with no comorbidities, with acute onset chest pain for 2 hours. We do an ECG. ECG reveals there is an ST elevation in 2-3 AVF. Echo reveals there is an LV-RWMA with an ejection fraction of 45%. So it's an acute MI. So we activate our acute MI protocol. We load him with dual antiplatelets, a statin. And nowadays we have started giving injection cangrelor because the action of ticagrelor takes some time till we finish the procedure. So we have a backup. And then we give a heparin 5000 and shift the patient to the lab. So his blood parameters looks okay with elevation of troponin levels and CKMB. His LDL is 156. So we do an angiogram with right radial root. So it shows there is an total occlusion of the LCX. LED is also diseased. RCA looks like a non-dominant, some disease in the RCA. But here the reading the angiogram is very important because there is not only total occlusion, but there is also calcification which is seen. In the epicranial view, we can see there is a calcification of the LCX over here, and there is some specks of the calcium seen here. So we thought we go in quick, come out quick. We wired it with a run-through workhorse wire, tried to dilate it with 210 balloon. So balloon is not giving away, and I find it very difficult to track the balloon down with a grating sensation. So what I do is I take a 2.5 into 10 cutting balloon to prepare the bed first and then advance the stent in. So after preparing the bed, the flows are good, and then I take a 2.75 33 Zions Alpine stent, deploy it. Stent expansion looks good, and then I upsize it with a 3 into 12 NC balloon, and I get a TIMI 3 flow. I'm happy, patient is pain free. I shift the patient to the ICU. 3 hours into the ICU, patient, I get a call. Patient complains of sudden onset chest pain, is diaphoretic, pressures are borderline. We get an ECG. So ECG shows there are steep ST depressions in lead V1, V2, and V3, which were not there post-plasty. So then we call him for back again for a check angio, and the check angio reveals there is a stent thrombosis. The thrombus is extending proximal part of the LCX. So where did we go wrong? So we loaded with antiplatelets, we've used Cangrelor, we have adequately prepared the bed, we have stented it and then optimized it. So first thing was to get establish a flow. We wired the LCX through with a run-through wire again. Some flow is established, but the vessel is full of thrombus. We pre-dilated to see what is actually the vessel. So after dilating with the 210 balloon, we see the flow is established. But now I've seen with my 2 eyes, the lesion look good, but now I have to open my 3rd eye, so I take an OCT. So OCT, to our surprise, shows that there is a severe under expansion of the stent, and there is some malopposition in the proximal portion of the LCX, loaded with thrombus, and the MSAs at the bend of the LCX is only 1.8 and 2.2 mm square, which is a grossly under expanded stent. And here also we can see there are shadows, which dark shadows, which doesn't allow us to see back, means there is a lot of calcification over there. So now this is how the stent is. There is a calcium deposit sitting behind, and the stent which we have deployed is under expanded. So it's a grossly under expanded stent. So what do I do now? So there are few options remain with us. Best is IVL. I go in, do a shocking to that stent, or I take a laser, do some lasing and then come out, or take a high pressure OPN-NC balloon, go high pressure, come out, or do a normal NC balloon dilation. So we decided we go with an IVL. First the balloon did not go in, so we had to take an Guide Plus support. So Guide Plus is an excellent crossable with an atraumatic tip, smooth to get in. We got our IVL balloon 3 into 12, delivered 80 pulses. And after delivering this 80 pulses, we again capture an OCT image. And in the OCT image, now we can see that there is expansion of the stent looks good. So we have achieved an area of around 5.5, 5.6, in the proximal part around 6.7. So we need to optimize that a little further because there was occlusion of the LCX. So we upsized it with 3 into 15 NC Trek balloon. There was some pinching of this OM, so we had to wire that, dilate it with 1.5 into 10 Rivary balloon, establish a flow, do a kissing balloon, and optimize the result. So this is the final OCT image in which we can see there is a excellent expansion of the stent, good mean stent areas, and the proximal and distal edge, there is no dissection. So this is how the final angiogram looks like. So there is a TIMI 3 flow. So if you see this angiogram and the previous angiogram, both angiogram looks the same, but the difference is when I look at it with my 3rd eye, which is an OCT, the picture is more different. So imaging helps in the decision making. So it should be done when you suspect that you're going to land up with an underexpanded stent when you deal with the calcified lesions. Confirmation of the calcium modification prior to stent deployment is must, because there are only limited modalities available to treat once the stent is in. And IVL is a safe and effective at managing stent under expansion due to inadequately modified calcium, or ELCA is another safe option in STEMI with under expanded stent. Thank you.
Yeah, thank you. Excellent case. Yeah. So sometimes we do get this type of things in an acute MI, which is not expected. So you suddenly find that it's very difficult to cross. You have to use CTO wires to cross, and then calcium. Yeah, I think you have managed it the right way would anybody would manage. So first you got a good result. It looked like a good result. Yeah. Maybe we could not have, maybe you missed out seeing in multiple angles or something, I don't know. So some clue to under expansion should have been there in the angio itself. But once you have a stenosis or reocclusion, then obviously you have done the best. How good is IVL in stent? Once you put a stent and then you find that it is not expanded, so does IVL work the same way as it is done in a without stent IVL with calcium?
No, it works. Actually, behind stent this is the one of the best modality to break the calcium. So only thing is some people, some report they were worried in bench tests, some polymer may gets damaged, but those are all very rare. But behind the stent struts, if there is a calcium, there are two ways only, laser and this one. But a severe calcium, such an under expansion, laser will not act. Only moderate calcium it will work. Either open NC with perforation more likely because grossly under expanded stent, severe calcium, the IVL is the safest. But malapportion and under expansion, you may miss an angiography. That is the reason when you find a difficulty, when some clinically is not correlating, always take the imaging. This is the case which highlights.
Post IVL you dilated with which balloon?
NC balloon.
Okay.
3.
Second, I wanted to ask the chairpersons whether it is okay to use a cutting balloon with a buddy wire inside the coronary.
No, once you put the stent, don't use the cutting balloon. See, it did distort the stent. It's
No,
a polymer.
I think there was a wire and you did a cutting balloon.
Initial.
Yeah.
Before.
So whether
Before.
it's recommended, whether it should be done?
No, before you can do it. After that, because he's mentally.
Before putting the stent, there was a buddy wire and he used the cutting balloon.
Before you can use it.
Before can be used.
You can use.
Okay, so I am working.
Because he's saying grating sensation was there. It was he prepared. Before that, he can use it.
By using the buddy
No,
wire,
we understand. Yeah. But it's not very
that
common.
Controlled
but there are people
dissections
who
can
use
go uncontrolled, and the dissections can spread to the peripheries also. So probably not
basically, I
recommended.
did not use this as a buddy wire. It was basically to protect the other
Whatever
branch.
may be there,
Yeah.
but there was a buddy wire, there was a wire, and there was a cutting.
I
balloon.
will tell
Two
you
wires
one
and
thing.
cutting balloon.
Buddy wire we use regularly. Most of the time, it won't any
That's
break.
not the
It
issue.
won't.
2 wires and cutting balloon. That is what I am asking. There were 2 wires, and still you are using over the one. There is a cutting balloon, and another one is just free.
So is there a worry of damaging the other wire?
That's what I'm telling you. It won't damage. We do regularly.
Okay.
Nothing will happen. We can use it. Absolutely. People think that it can cut the wire, but very unlikely. It's very safe. You can use. We use regularly.
One more thing. Means I am working in the periphery, and once you see the total occlusion, you are hyper. You just try to establish the flow as early as possible.
Absolutely.
And I may be wrong, but when it is total and there is a thrombus, we try to do the direct stenting, which is wrong. But most of the times we do. So until unless you inflate the balloon, you will not know the nature of lesion, because in periphery we don't have the imaging. So what's the middle solution between the two? Thrombus, you have to dilate, you have to clear the thrombus, and a good result.
I will tell you one.
Unless you see the distal vessel, you should not stand, according to me. So there's no
Distal
question
vessel
of
has been seen. There is some moderate thrombus, and you are planning for a direct stenting.
In periphery, according to me, you should be safe. So do a dilatation. Now you will know everything, whether the balloon is expanding or not. There are pros and cons of doing dilatation also, but then it is safer to do that, I would say.
The calcium, always you feel a grating sensation. When you are passing the balloon, if you are feeling the roughness, that grating sensation, always you suspect the calcium, and that time you have to adequately prepare the bed. So you are giving a thrombotherapy. No matter whatever dose you give, once under expansion is there, is bound to close. So the only way, expand the stent. If the stent is expanded, flow is good, then stent thrombus will not. You may have a result on the table. You may have a wonderful result. But once you shift again, ISR chance are more, stent thrombus. You have to prepare the bed. Otherwise, shift to some other. Or if you have open NC, try open NC, slightly 0.5 mm, less than the diameter, actual diameter. Maintain 40 to 45 at least, prolonged. Sometimes with one inflation it may not, but you have to repeatedly inflate. In 3-4 times if you inflate, most of the time it gets. Because the IVL, when you are giving How much atmosphere pressure it generating? Only 50 atmosphere. This open ends also is 40, 30, though company says 35, 40. But many operators, they go, if you are undersizing the balloon, you can go up to even 55 also. But prolong the inflations and keep it there. Sometimes it gives. Even NC also, sometimes you may have like a dog bone effect. But repeatedly, multiple prolonged inflations if you give, it yields. But you should have patience. But as long as you get the, don't leave until you get the very good expansion.
So in periphery, I would say you do always do multiple angles, or you can move the table as you are expanding the balloon. There are ways of finding out for people who cannot have access. Like I also don't have access to imaging immediately. I have to order for it. I don't have it in my hospital. So you get away with most of the time, and I'm telling you, if you do these things properly, you can always identify if there is a problem. There is absolutely imaging will be required afterwards. But short of that, these are the only way you can deal with those things. Yeah, thank you. Well, let's move ahead. Thank you very much. Dr. Ganesan Ramchandran. Finally, the light at the end of the tunnel. Yeah, let's see. So we have 13 minutes for 2 presenters, so please be on time.
So good morning to everyone. This 76 years male, thin, frail male presented with chest pain and dyspnea for 2 days, a late presentation. He is already known case of diabetes, hypertension, dyslipidemia on medical management. He also underwent CABG 2015 and Lima to LAD and SVG to OM. And he also had a stroke 2018, right side hemiplegia. Is not that much ambulant, but not also bedridden. And he also having a chronic atrial fibrillation. It's, at the time of presentation, his blood pressure was 170, heart rate is 110 per minute, saturation is 85, and bilateral basal crux was there. And ECG shows atrial fibrillation with a fast ventricular rate, and also ST elevation, Q wave in anterior leads. Echo shows severe global hypokinesia of LV, anterior wall greater than inferior wall, and severe systolic LV dysfunction, EF 30%, and severe TR is there, moderate MR. And the CBC RFT was normal, and the angiogram we did it. This is the native vessel angiogram. Left main seems to be fine, and the LCX, mid LCX 100% occluded, and LAD after proximal to mid LAD is a diffusely calcified mild lesion was there. After diagonal, LAD 100% is occluded. And the distal RCA, precrux RCA calcified, some 99% stenosis is there, but the terminal vessels, PDA, PLB seems to be a small caliber vessels. And this is the graft angiogram. SVG to OM was fine, and Lima to LAD is totally occluded. With this background, we have certain questions. This is an anterval MI, and which is the culprit, here Lima or LAD. And in this post-CABG scenario, which vessel is preferable to intervene, either graft or native vessel? So I prefer to use to intervene native vessel than graft vessel, because this is the general consent statement was there. In any post-CABG patient, native vessel intervention is more preferred. So I passed wire, pre-dilated with 1.5 into 10 balloon, no flow was there. Then I dilated 2.5 into 12 balloon. Some TIMI 1 flow was there. So we put, because a patient in cardiogenic shock, we cannot take time to, too much time to prepare, establish TIMI 3 flow, then putting the stent. So we put the stent 3 into 38. And this is the result. So terminal LAD is not filling. I give an intracoronary nitroglycerin, tirofiban, nicorandil, and whatever it is there, everything tried, but the LAD stent is gradually sinking into the thrombus.
No, actually, there is a distal thrombus. It distally migrated earlier.
Yeah, that thrombus is migrated from where?
Migrated there. That is totally
that is the question.
Unless you take.
Yeah, thrombus is from where it is migrated. I think it is migrated from the Lima. Lima graft to LED.
Possible.
So we give, even after thrombus aspiration was done, a distal vessel again pre-dilated with a 2.5 and 2.75 balloon, and there is no flow. So terminal, almost we went up to terminal LED. I cannot go beyond that with a 2.75 balloon. It may perforate.
So did you get anything in the aspirate?
Nothing.
No, actually, if you see the first film itself, not only proximal, see even distal LED not flowing. Distal LED totally full of thrombus. That time if you put
no, TIMI one flow was there. That's why we put the
No, just go back. Nothing was there. TIMI grade flow up to just to distal, but beyond that,
no,
up
that
to apex.
that fluorostore image is not. I didn't.
No, it's not there. Actually, what is in this case? If you see, there is a proximal tight lesion. During that time, see a lipid-rich plaque. What happens? There is shower of thrombus. Necrotic material go distally, and it will fill it. Now the entire distal LED, as long as you don't open the distal LED, we are not supposed to put the stent. Once you put a stent, because all the metal, it begets the thrombus.
Lesson number 1.
Yes. So there what you have to do, take a small balloon, 1.5 balloon, go to the apex, very small balloon, 1.25, 1. Create a channel. What happens, some antigrade flow is there, it flushes. Then thrombus gets cleared, wait, give glycoprotein to be, wait. And once you get some flow, that time implant the stent and upsize the balloon and expand it nicely. Even that stent also, there is under expansion. See, already distally flow is not there. That begets the thrombus. Thrombus begets the thrombus.
Tell me, which drug did you use? You did thromboaspiration. So did you give anything to that aspiration catheter? Because that's the
No, I used another technique. So we deliver the intracoronary vasodilator cocktail through the perforated coronary balloon into the distal vessels.
So why you have used this thing to use another balloon, perforated?
Yeah, you are perforated. After that only I received.
Which drugs did you use? My question is, which drugs did you use? Which are the best drugs for
Cocktail we will use tirofiban, nicorandil, sodium nitroprusside. We all used all 2 ml. Yes.
all three?
Yeah, all 3 used together in single syringe in 10 ml. We will given in distal most LED. The first angio shows distal most LED. After that, flow was established. You can see in second.
Flow got established. You see the middle this thing. So now, in such a patient, you can put IVP just to.
Yeah, we did everything.
Okay, good. Thank you very
So
much.
this is
We
the
move on to next,
third after him deploying the stent. TIMI 3 flow was there. We put on patient in dual anotrope mechanical ventilation.
Hope that the flow improves in the microcirculation. Thank
so
you very much.
post-CAB subgroup coronary interventions are complex. Native vessel interventions are preferred over graft intervention. No flow phenomenon, one of the common complications in late presentation is STEMI. Delivery of intracoronary vasodilator cocktail through the perforated coronary balloon into the distal vessel is more effective than just giving through the guiding catheter.
Good, wonderfully done. Yeah, but only thing is, only take home point distally.
We'll move on to the next. Can Dr. Suraj Narsimhan, is he here? Sir, please come. Please come. You come. Dr. Suraj is not there, so we have 5 minutes, 6 minutes more. So let's discuss this. This is very interesting. Now, does everybody give a cocktail? I generally use sodium nitroprusside. That is I am sold on that. So I put a microcatheter. I use 50 mics sodium nitroprusside. I ask my anesthetist to keep vasoconstrictors ready to give intravenous 6 milligram. They give Ephedrex. And you get hypotension always when you give this sodium nitroprusside.
In this cocktail, I will use adrenaline also, 1 in 10,000 dilution.
No. So we are discussing whether cocktail is the treatment of choice or whether a single drug, because nitroprusside you have to give 50, at least I give up to 500. So usually things improve to the best of my understanding. That's my experience. So what's your experience? How do you go about?
Doctor, first of all, you did a wonderfully nice case. Only thing for discussion sake, what we are saying, frankly you did only thing is my observation, before implant the stent, you have to put all these measures. See, establish the flow, because distally I feel totally full of thrombus. That time if you are putting proximal stent, because all the distance it gets, even the thrombus will form on the stent also. That's what happened. There what happened, distally same you can give like adenosine, you can give nitroprusside, you can give adrenaline. Most important, glycoprotein 2b3. Add-on therapy, that you can give. Suppose if the same patient is coming early to the hospital, thrombolytic therapy, ganglion is the best drug.
Glycoprotein, is it given in that cocktail? I have never done that.
I will give.
No, you have given in the cocktail,
yes,
you said.
I have given.
So he has given in the cocktail. This is not described. You are describing something which is new for us. So we have to let everybody know that you have done this, but I have to also say that this is not, to the best of my understanding, tyrofeban into the cocktail to do microcirculation has not been described to the best of my understanding. Have you got any publication or any data on this?
So we are giving intracoronary. There is no publication.
Cocktail.
Don't say
intracoronary
cocktail
tyrofeban
is
given. The
something
same
different.
logic applies
Yeah,
here
so that
also.
the main idea is you have to get that distal flow. Without that, one should not put a stent. That is number one lesson I said. Yeah. How you get the flow, how many drugs you give, depending upon your hemodynamics is this. And finally, if nothing happens, we give them intracoronary IV tyrofeban and put an IBP and sift the patient too, because you can't do anything more than that. Yeah. Yes, sir.
You had a thrombustor. This thing.
But he didn't get anything through that. The other thing is, the best thing according to me to be done before you go ahead, because I wanted to tell that, is I put a microcatheter and I give an injection through the microcatheter. The advantage of that is, if the distal vessel opacifies very well, then you know that there is no clogging of that. Problem is proximal to that. If you have problem with the microcatheter, there is no flow, then you know that the distal is a problem. So that is a way to distinguish between proximal problem and distal problem, why the flow is becoming slow. All the time we think it is thrombus in the microcirculation, but it may be a dissection which is proximal, which you are missing out, and that's why the flow has become slow. These are theories. You might have done it, but let others know. Na?
I also used microcatheter multiple times, but this
good.
balloon better.
No, we are not commenting on your case. We are just discussing in general now. We are discussing in general.
Said that the GP2B cocktail, you can use it when you want to use a bolus of 15 ml. Out of them, 5 to 6, 8 ml you can use intracoronary separately, and then you another 8-10 ml IV, so that it makes a lot of sense. Another gentleman was asking about the cutting balloon there. We also use regularly, like Dr. Sridhar told, but the wires and the balloons are vertical blades. We don't cut it at all. If it is horizontal, it can cut. If it is vertical besides that, so it's very likely that it will cut that at any time.
And one thing is my personal experience over the last 35, 40 years is I give 2B3 inhibitors after everything is done. The reason for that is, by chance you have some dissection or some small perforation anywhere which you have not seen, you are in trouble. You can't do much after that. So just ensure that your coronary tree has no major issues and only thrombus is there, then you are free to give. I nowadays never give it first. Many people, previously we used to give Riopro and then do the angioplasty. But then we have faced problems with that, because you will end up in some complication, then you cannot take back your Riopro, you are stuck with that. So managing that is, heparin you can always manage, you can reverse, you can do so many things.
Actually, guidelines removed from primary therapy, only during cath lab, in the cath lab, during procedure, they add on therapy. Suppose slow flow, no flow, after despite doing all measures, if nothing happens, you can use the glycoprotein therapy, as per the recommendation.
We are also using same way only. If no flow or slow flow is coming, then only we are giving.
Absolutely fine.
One last
Good.
question.
Yeah, please.
Thrombotic total occlusion. You did the stenting. You came out in 5 minutes. How much common is in your practice that after 3-4 days or 2 weeks, 3 weeks, you take patient back for the post dilatation? You are not satisfied with the expansion. You want to expand. So when you will expand, or whether this is done or not?
No, this is done. This is done routinely if you have a problem and you don't want to. So you give thrombus treatment, keep them in ICU for 24 hours. Generally, I do it after 24 hours because you can't keep these patients for a long time in the ICU or something. So after 24 hours, if you are given so much of medications, the thrombus has to go. I don't think the thrombus will remain. You require 3-4 days of treatment. That will be very unusual.
I'm asking post dilatation. You are not sure about the position because the thrombus was heavy.
I understand that. So you have a doubt. So if you feel, if you're worried about expansion, then you definitely, and there is no thrombus. Okay? That's what you're saying.
Yes.
So then you bring the next day, na? What's the big issue in that? Yeah,
So my question is now, in this case, Lima would have been attempted in your experience, or you will do LAD?
No, I would have done LAD. I don't know about.
Because the culprit is lima, seems to be thrombotic occlusion in lima only. LAD is not.
Frankly, LAD, though it's very short segment tight lesion is there, thrombus is there, easy to. When native vessel is there, give priority to the native. Lima is more prone for spasms.
In the spasm dissection is there.
And you don't know the course of that lima, you know how tortuous it is, what has happened to it. Nothing is seen there. It's not best to touch that. Yes, sir.
One point, when we achieve a TIMI, let's say TIMI 2 flow, and the distal circulation is not clear, and the patient is unstable, what about postponing the procedure for the next day or after giving, let's say, triple therapy, and then we bring him back? This is, I think, an option.
No, he's saying in the presence of massive thrombus. Suppose people, what they're saying, we go high pressure, sometimes it further aggravates slow flow, no flow. But 99% of the time, they go with aggressive dilatation and see that the stent is expanded. They don't postpone.
Yeah, I mean the decision, as you say, this is, I think, is very important point, not to rush to stent. Unless you have a very good distal flow.
Absolutely, you are right. You're right.
Absolutely, you have to.
You can always bring the patient on the next day. Yes,
we cannot prolong the procedure time, so we can postpone the procedure until everything.
And remember, when you do second dilatation, many times you get slow flow after the post dilatation rather than the first dilatation. So if you, many times I feel if I have the adequate result and it was a soft lesion, you should not do post dilatation also. That's my strategy. I may be wrong.
Squeezes the thrombus. Again, when
it
you
also
go high,
squeezes the thrombus from the stented area where the thrombus has already been now broken down into pieces because of your stenting, and that comes down and then creates problems for you. So these are things which you will face, but you have to be ready for all these things. Okay.
I have a question.
Point.
Yes, sir. Aren't we giving a bit too much of credit to this cocktail of drugs having helped him in clearing the thrombus? In my opinion, I don't think it's the cocktail that helped him.
Yes.
Instead, it is the overall improvement in the hemodynamics. I think to tide over the complication, he put in IABP, didn't you?
At the end of the procedure, after establishing TIMI 3 flow only, I put.
After
IABP.
establishing,
sir, we agree with you.
Patient is
We in that type of a situation, we do everything. You cannot make out what helped you. So long as you are helped, thank God, and then go ahead from it. Thank you very much for a nice session. Thanks to you for being chairperson with me, and for everybody for participation. Thank you.
The next session is left main interventions, 6+2 minutes. The chairpersons for this case presentation session 50 are Sanjeev Gera, Umeshwar Pandey, Gajendra Goyal. And the discussants for this case presentation session 50 are Nitin Tiwari, Nitin Sonune, Ajharuddin Malik.
So this is the last day. I think many people have to catch their slides. So can you put the slides on? Yeah. So what I'll do is I'll skip most of the slides, and I deliberately chose a case which I did more than 10 years back as a live case of trifurcation angioplasty. You must have seen in these last 2 days a lot of use of Impella, a lot of use of imaging, and in this case nothing was used. So I'm not advocating that this should be done in today's technology, but I'm just telling you, if you don't have access, it can be done, and this will raise more questions. So I've deliberately put it. So we'll make it more interactive. I'll skip the slides because most of the things you have discussed in last 2 days. So trifurcation is an extension of bifurcation, so it becomes little more complicated. You fear a lot, the cost goes up. We won't go into the details of whether we should do a bypass or an angioplasty, because whenever we are in this type of meeting, we always say patient wanted angioplasty, so we did the angioplasty. So we won't go into that controversy because that's a separate issue. So basically you choose based on these clinical risk factors, lesion morphology, angiographic pattern, you all know this. So this is just borrowed from the bifurcation. This trifurcation is just an extension of two bifurcation, it becomes a trifurcation. So the same techniques are applied which are for bifurcation for a trifurcation lesion also. See, the same angulations are discussed, same classification is there, and this is the simplest. So if both branches and left main is involved, is called true or type A. If only branches are involved, it is called type B. So that's okay. So this we also know that it is the side branch which are important for bifurcation. Same is true for trifurcation. Here there are two branches instead of one. So all the rules apply. So this is a case I did live, I think more than in an NIC, about more than 10 years back, but I'll show you. So we won't go into the indications. So this was the angio. I'll show you the different views, hopefully. So you can see all the three branches are involved. And all three of them are significant branches. So this is a still picture. So now you can make up in your mind what you want to do. So there is no guidelines on trifurcation that you should do this procedure. Like bifurcation, you have EBC guidelines that go for a so-called layered provisional stenting versus DK. They don't believe in DK crush, so they have their own theory. So the Chinese believe that DK crush is best. Scientifically, DK crush is better technique. But how to apply out of these two branches, which technique is open in trifurcations. But in this case, we decided that we will stent all the three branches. So we can discuss why you decided that. And no imaging was done. This was because we had non-invasive assessment that patient has myocardial ischemia, this, that. So that will be one point you can ask, sir, why this was not done. So I deliberately brought this. Right was normal, so no IABP or no impella has been put. The access to the left is available. That was taken. Now what you will do, I'll skip first slides and leave more time for discussion so you see that left main is significant. So all three branches have to be wired. Up to there, I don't think any controversy. Nobody, if you are disagree at any point, you can come and ask me. So up to this point, I think everyone will agree that we put three wires. So this was done. So all three were dilated. I think there will be no controversy till that point. So all three were dilated. So this is the post balloon. Patient stable, no impella, nothing has been done. So now if you have to put, say, three stents, you can discuss why put three. We can put two, we can do primary, we can put balloons instead of. But if you decide to have all three branches stented, I think this is the easiest technique which you can do. You put a stent from LED to left main, you obtain the results, then do like bifurcations. Imagine those two are branches, recross, dilate the stents which you have put the struts from the left main to LED. Again do a tracing. Now you are doing a tap in both the branches. So simultaneously you have put 2 stents in those 2 branches, the ramus and the circumflex. Already there is a stent from left main to LED. So we have done basically a tap in both the 2 branches. So it's quite a simple technique. Yeah, it's finished, don't worry. So this is what you obtain. All 3 stents have been done. So this is the pre and this is the post. So minor things you obviously you require a bigger guiding catheter if you want to put 3 stents. See, same bifurcation techniques can be used. So these things you know that you have to do pod this, that. So I'm not discussing this. So now I've left it for your discussion. Any specific points you have and alternative thoughts you can give. It's open. Yeah, go ahead. 10 years I don't have. 1 year patient was okay, so I don't have the 10 year. If I had, that would have been a very ideal thing. In AIMS, it's very difficult to follow the patients. They go back where they came from. So I don't know the outcome of 10 years. Outcome is there. I just picked up this case just to see that you have seen so many of Impella and this and that. Don't go back to your peripheral center thinking that if you put one Impella or you put IVAS, you put these, the cost will be 40-50 lakhs. So not everyone in India can afford that. So this is not saying that you don't do that, you can do that, but provided the right is normal and LV is okay. If those 2 conditions are met, you can take the patients. But if those are not met, then you require something more.
How we go for the post dilatation? We do by sequential or we do tracing in most of the cases?
You go sequential and then do tracing. The same principles apply as for bifurcation. Okay. Just remember, because you have to do the high pressure for the branches and then moderate pressure for the. So same principle will apply. So just think them like two bifurcations.
Like tracing is almost essential after the
procedure.
procedure.
That is essential. Yes. If you put like in bifurcation, if you do a provisional, you do a kissing or not kissing is controversial. But if you do the 2 stent technique, if you don't do kissing, the procedure is incomplete. If you look at the previous results of all the trials, the kissing was the main thing because that was done post only in 50%. If you don't do the kissing, there will be a trouble.
And what do you think the best technique for this decay crush, or you think we do now nano crush also in many of cases? Because the side branch loss.
See, if you have to do crush, now imagine which, like in this patient, which branch you would have taken.
Yeah.
So one of these branches you will have to do something. Either you do balloon, drug-eluting balloon, or do the tap or something. So you have to choose the 2.
Yeah. But because some
I find this is the most simple technique if you want to put the 3 stents. Just you have to do left main to LED and do tap.
Yeah.
There's nothing.
Nowadays we have seen cases in the conference, they are doing nano crush in many of these. First they do the side branches, then go for the LED.
The crush has the 2 basic modifications. Crush, people thought we are leaving a lot of metal around. No? So to avoid that metal, they are doing this nano, you call it mini, we call it whatever crush it is. So that is first principle. Second is because the final kissing was difficult, so they made it 2 kiss. In first kiss, only importance is to open the branch before you put the 3rd layer. So once you have opened that branch, your wire will easily go. First kiss has only that much of utility.
So always in trifurcation, we have to go with provisional stenting only.
Yes.
And I always, most of the time, we will do 2 stent. One third vessel, we will better go with the drug-coated balloon here, because if you put 3 stents, the carinal metal crunch will be more on the long term. results may not be good. So
Yeah.
2 stents, if possible.
I
Another
have
you can go with.
I have deliberately not brought you the case series which are available. The highest case series available is 44 patients. So all sorts of techniques have been used. So we don't know which technique is better. What you use is the best technique. You can show a case showing I used 2 drug-eluting balloons and used a stent in left main to LAD, and that is the best. I'll agree. That may be the best because there are no guidelines. It is your personal experience. What are you are comfortable with? But I find this anybody can do very safely because you have secured the LAD to left main. Now these instead of 2 stents, you can put 2 drug-eluting balloons. The same results will come, provided there is no dissection or no zone flow. Yes.
Sir, guiding was 8F?
Yeah, that time it was 8F because maybe 7F with a higher lumen also can. Yeah, it was 8F.
Yeah, very nice case.
It was a live case, so that done in about 30-40 minutes because this is a very easily done. But this may not be every case. The patient, the side branch may occlude. You don't know. So all those things are. We can say I was lucky. So, but I find nobody can challenge that this is very simple technique.
I mean, very nice case, but as I said, as the previous speaker said, less stent is always better.
Yeah.
So, I mean, if personally, I mean, there's something called a reverse.
I personally am a believer of 2 stent technique even in bifurcation. Whenever I debated with this European club, yesterday also I debated, because if the lesion length in the side branch is more than 10 millimeter, no stent in earth can go and cover the tens. So you decide that I don't want to touch the side branch. That is your choice. But one stent will not cover the side branch, especially in left main circumflex will be a large branch. So if the lesion is less than 10 millimeter, if you look at the DK crush and EBC main, which they advocate, this is the difference is between the side branch length. It is 7 versus 17. They could get away because it was the average length was 7. If you have an ostial lesion, your stent will cover. The 3 millimeter will be covered. Ostium is covered with stent. But if it is 10 millimeter, it won't cover. So 7 millimeter you have left and decided I won't touch it.
Correct. It will not
Number
matter
one.
for
Number
a
two.
small,
Yeah.
branch. If it's for left main, yes, it will matter. But if it's a non-left
In
main, it will not
a
matter.
small branch, why do all this? Just
Absolutely.
put a stent. Don't
Correct.
do
Single
even
stent,
kiss.
provisional,
Don't do. And
provisional will
I
be
have
better.
also an objection of doing a kiss in the provisional, because if you are kissing, we were taught in the olden days, if you kiss, the restenosis rate is more than 50%. Now you are saying just kiss it and come out if flow is there. So the restenosis will be higher in
But
without
you'll have
stent.
to take a 1-to-1 or even a less 0.5 millimeter less balloon so that you're not causing more damage.
It can be.
And as a point I wanted to make was there's something called a reverse tap, because one of the proponents of this was Dr. Tony Gershlich, who was one of the greats of cardiology.
Yeah, I know.
He was my mentor.
Yeah, I also worked with him in Leicester.
Correct.
I know him.
That's I always prefer, rather than the crush and the mini crush. So we do rather than a tap, it's a reverse tap. So you put the branch, the first stent in the branch, and then you kind of get it across, and then the main would be the LAD to left main to LAD. And then he had fantastic results with all this. So I think it's one of the.
It's whatever technique you learn. I just presented this because I think there is no simpler technique than this.
Yes.
If you want to put 3 stent in a trifurcation,
Absolutely very easy.
very easy and very safe, because you have already secured the left main to LAD. So that is the I just thought I will bring it from my things. Okay.
Thank you. Thank you, Dr. Bahl. Now the next presenter is Dr. Amit Khandelwal. The case is complicated left main angioplasty in cardiogenic shock with CH.
Good morning, respected Chair and dear friends. At the outset, I would love to extend my heartfelt thanks to indialive organizers for providing me the opportunity to present this case. Well, left main primary angioplasty in inferior posterior wall STEMI with complete heart block and cardiogenic shock. I don't have any potential conflicts of interest to report for this. This is the case brief. 60-year-old, non-diabetic, non-hypertensive gentleman, father of one of our dermatologist colleagues, presented in ER This was the case done on some day of September 2021 with severe chest pain, nausea, vomiting, sweating for last 2 hours, which increased significantly for last 15 minutes and was associated with intense ghabrahat, sinking feeling and drowsiness of the patient. On examination, pulse was 50 beats per minute, blood pressure 70 by 50 millimeter of Hg, respiration he was tachypneic, and lungs were having bilateral crepitations. ECG showed inferior posterior wall STEMI with intermittent CHB. Now, echo was showing moderate LV systolic dysfunction with EF of 35%, with RWMA in posterior inferior wall of LV with preserved thickness but with moderate MR. So he was immediately shifted to the cath lab for TPI and angiogram as well. After angiogram, what we saw was this. Now there was critical lesion in the distal segment of left main. Otherwise, LCX was looking and LAD were looking more or less healthy, although some proximal lesions were there at the ostium of both, but RCA was codominant and normal. Now what we were dealing was whether it is a critical thrombotic lesion or some sort of dissection. Why patient had inferior wall MI? Was it because of the dominance of LCX? So how to approach? I mean, primary PCI to LMCA to LCX considering the CHB, primary PCI to LMCA or to LAD, or primary bifurcation straight away to stent strategy from LMCA to LAD, LMCA to LCX. Now I could over here the attendants were discussing something about like if it is very critical, can we go for CABG? Now fourth option was like just stabilize the patient with TPI with inotropic support, medical management, and then can the patient be deferred for CABG, can be taken for CABG. So in the meantime, the patient had cardiac arrest. Patient went not into VTVF but was possibly because of the hypotension. We immediately took the patient for primary LMCA to LAD 3.5 into 38 with drug loading stent. Workhorse via BMW was passed, ballooning was done, and immediately took up the stent from LMCA to LAD. After opening up of rest all LAD was good. NC was done just to stabilize the bifurcation, but there was something which was looking like ulcerated lesion at the ostium of LCX. Maybe the plaque shift, maybe the lesion which was present earlier also, which we were not able to see in the previous angiogram. What I thought of was just to open up, do the ballooning first and see what exactly is the result. So I took up the whisper wire, passed through the distal struts into the LCX and took 1 into 8 millimeter just to open up the struts. After that also, we could see there was some lesion still, 2 into 8 millimeter semi-compliant balloon again, but still dirty. Then we thought of like, let us stent it with the tap technique, 3 into 15 millimeter into LCX, but I kept the NC balloon also 3 into 12 millimeter in the mid part of LAD. Opened up the stent by tap technique and thereafter took the balloon backward of LAD and did the kissing. Again took NC 3 into 10 millimeter, did kissing again. After that, the balloon which was taken for LAD did part of proximal or body of left main and took 4 into 12 millimeter again NC for tapping of LMCA. And this is what we could achieve later on with good apposition, TIMI3 flow. So what exactly we learn from this? Primary PCI in emergency always score over CABG. There are multiple techniques of bifurcation stenting, but adopt the one which is actually more comfortable you are with, and of course with decent long-term outcomes, and sometimes it becomes an emergency to do the simpler techniques. Final part and kissing are must for bifurcation. Imaging should always be preferred, but sometimes you are trapped in such a situation that you can't do that also, and sometimes it's not emergency. It's not available also. So always anticipate the trouble, and you need to have caution at every step. It may be dreadful, but is rescuable. With this, I would love to sum up the presentation. Thank you very much for the patient hearing.
It's a good case. The presentation was like inferior MI. Why we didn't go from the left main to LCX if the presentation was inferior MI?
So this is what actually was the second option, sir. But the patient had cardiac arrest. The patient had cardiac arrest. I was always aware, like, it cannot be, I cannot risk LED. So just secure the LED first. I can always take over into LCX. But doing left main to LCX, I may perfuse the culprit vessel, but if LED at all, if something is happening, I may not get some more time to secure that. So that was the only main thing.
And what is the size of the pot balloon you use?
Final was 4 into 12 millimeter.
Because 12, I think it was going up to the carina.
So this was 3.5 into 12 millimeter of LED.
Okay.
And the final was 4 into, because it was LMCA, and the final result was good, so I could use that.
The main thing is we have to avoid the carina when we are doing pot, because otherwise the results of kissing all they go in.
Yeah.
So any questions from the audience? Thank you, Dr. May.
Thank you.
So the next presenter is Dr. Hari Om Tyagi, and the case is left main to LED CTO, PCI by anti-gate approach with the micro catheter support.
Good morning to all. It's not moving. Can you help me? Good morning. So this case was 38-year-old male presented with complaint of exertional chest pain and dyspnea grade 3 and 4 for last 10 to 11 months and increasing for last 10 to 15 days prior to admission. ECG shows sinus tachycardia with some RSR pattern in precordial leads. Deep Q wave in inferior leads. Echocardiogram shows inferoseptal hypokinesia with ejection fraction 40% with mild mitral regurgitation. So angiogram shows left main with triple vessel disease, distal left main critical 80% and ostial LED CTO, LCX ostial proximal minimal disease with mid 95%. RCA mid CTO with distal vessel filling through bridging collaterals. So patient was advised for CABG. This case was angiogram was done by me 1 year back he told me that at that time I also advised for CABG, but he admitted somewhere for 2 to 3 times for bypass surgery, but not able to get it. So that's why again he came to me to go for angioplasty. So again angiogram was done. The scenario was more or less similar, but otherwise the LCX lesion was increasing at this time. So this was the angiogram. It shows critical LCX and ostial LED CTO. Distal left main critical around 80-90% disease. This is the right coronary artery, bridging collaterals, mid CTO. But contralateral flow to the LED was not so good. So after getting the high risk consent, patient was shifted to CCU for 1 day and take the advice to with the family consent, and morning it was taken for angioplasty. So this was first the EBU catheter was taken, but because the left main was short and distal left main is critically diseased, so patient was not supporting the EBU catheter. So the patient blood pressure falls, though we shifted to JL 3.5 7F because the support is not good with the JL catheter. Even with the JL catheter, if we engage fully into the left main, patient blood pressure is not supporting, it goes down and patient becomes symptomatic. So somehow by keep that the mouth and the JL catheter with micro catheter, Sion blue was parked into the ostial segment of the CTO portion into the LED, and then changed to pilot 150 through the microcatheter. The proximal cap was able to cross through the proximal cap with the pilot 150, but distal cap was not able to cross with this one. So we changed to Gaia 2 with the microcatheter, but this Gaia 2 after crossing the distal cap was stuck with the microcatheter with the so I remove all the system, and somehow after crossing the distal cap with the Gaia 2, this regular wire Sion blue was able to cross the distal portion into the LED, and tried to negotiate with the 1.2 smallest balloon to negotiate into the CTO portion, but was not able to cross that one. With multiple efforts and changing the balloon and deflate and push, I was able to cross the proximal cap, and after that upgrade to the higher balloon size 2 into 10 semi-compliant balloon. After 1.2 there is some small flow is there into the LED, and after serial dilatation with a 210 and 2.510 millimeter semi-compliant balloon, this was the flow. So the patient have multiple dissections level and develop some chest discomfort and agony. After this, so my plan at this point also, at that point also, because if that LED was taken first, because if LED is not going to be cleared by me, then I can advise patient for the CABG. So that's why the LCX was not done at previously. So after this, LCX pre-dilated and stented with 3 into 23 millimeter stent. After stenting to the LCX, now we have to take from a left main to LED. So this was 2.75 into 24 synergy was taken from left main to LED. After parking into the proximal healthy segment into the left main around 6 to 8 millimeter proximal. So, and because distally there are diffuse disease in the LED, some landmark was chosen to park this one. So, and post dilatation done with the 3 into 10 millimeter balloon, and proximally it's proximal optimization done. But that the distal portion of the LED, the significant lesion was there. So after again taken the small balloon 2.5 into 10, it was pre-dilated and stent try to take the stent. But at this point, patient developed ventricular fibrillation, and because the flow into the LCX was gone, the procedure was prolonged, so I have given 2-3 times heparin, but some thrombus formed from the left main to LCX. So after flowing to the LCX by giving GP2B3A inhibitors and some supportive treatment, so ballooning was done to the LCX portion. After that, the stent 2.5 to 12 millimeter distal portion of the LED distal to stent was done. And this was the final result of the case. Thank you very much.
So,
yeah, left circ ostium is not okay, but because of the complexity of the case and patient developed the arrest in between, so I leave it like that after ballooning to the LCX portion. And because initially also the LCX ostium was minimally disease, not significant disease, so I don't want to mess up the again in the after 2.5 hour procedures. Nothing can be done. Patient was this case was done in January 2017, and he is in regular follow-up, and is okay, no problem.
I think distal lesion in the LED could have been treated earlier prior to deploying the stent from left main to LED.
Left main to LED, because distal to that portion of the stent is also LED, the diffusely disease. So if we take the smaller balloon or larger stent from left main to LED, it may be difficult to tackle the distal portion. So first mark at the landing zone into the mid portion of the LED, left main to LED done, and after the left main to LED, the small balloon we can take distally like that.
But I think overall patient is an ideal candidate for bypass surgery.
Already I advised the bypass surgery 1 year back to that. So yes, he was admitted for 2 to 3 times in the General Hospital Delhi also for CABG, but not able to get
bypass
it.
Is a big no. We should have treated the L6 lesion first, I think, because during the procedure if something happens to the L6, so it would have been
because keeping in the mind that at this time also if was not able to cross the LED, then I will send again to the bypass to the patient. That's why I tried the first the LED CTO, and if it is possible then only the LCX done and then good. If I put the LCX first and LED was not going to cross, CTO was not crossed, then what the significance of for send for the CBG?
Your left main stent was only 2.75 millimeter.
Yeah, it was synergy, and it was post dilated 4 millimeter balloon.
And after that you were comfortable with the sizing, and did you do the pot and?
Yeah, it was pot.
Thank you.
Thank you.
The next presenter is Dr. Himanshu Gupta. Left main when less is small. The next presenter is Dr. Suraj Kumar. The case is stent loss. Dr. Jamil is not here. Dr. Jamil, yeah, that's great. So, Dr. Jamil cases, don't chase the MSA every time.
First of all, this is not a left main case. I don't know why it was included in this session. Okay. My patient history is, it's a 54-year-old male patient, is diabetic hypertensive, dyslipidemia, and he presented with exertional angina for the last 2 months. He was admitted 1 day back with the NSTEMI, troponin was positive. And the basic investigation was normal. Echo was normal LV, there is no significant RWMA. ECG was showing some ST depression in the chest leads. So this is an angiogram. The angiogram was the diagnostic catheter was not engaging properly. Why? Because the LAD and LCX was having a separate origin. But you can see the lesion in the LCX, in the OM and in the mid LAD. So this you can see that there is a tight lesion in the OM, and the mid LAD was also showing a tight significant disease. This is a selective cannulation to the LAD. The mid LAD was showing the tight disease. So our plan was, it's a straightforward case, nothing complicated in it. Just go stent these two areas and come out. First of all, this is the plan, and I wired both the OM, both the branches I wired and dilated. Then I both the branch and stented it, and the result was good. That is, the flow was good. Then I went to the LAD. LAD angiographically there is a tight stenosis. There is no significant calcium. So I thought it will be a straightforward case, put a stent and come out. But the problem happened here. The problem is, initially after wiring it, I put a 2 SC balloon and started dilating it, but it was not dilating. So it was a very hard lesion. So I thought I will just image and see what is the nature of the plaque there. So this is what the IVUS showed. IVUS was showing predominantly a fibrotic lesion, but at the tightest point you can see some calcium over there. Even though the calcium was only for 3 to 4 mm, and it's an eccentric calcium, and the arc is maximally extending up to 180 degree. And the tightest area was showing an MSA of 1.93. So with this information, I thought I will go a little bit aggressive dilatation, but the size, if you EL to EL, the size is more than 3. So I started preparing, with this information, I started preparing the lesion. So this is the distal landing zone. These are the information. Distal landing zone, the area was around 5.17. The tightest point is 1.93, and these are the other things. So proximal 9.3. So for this information, I got where to land, what to do. So with that information, I started dilating the lesion. For initially, I started with 3 NC balloon. Still, you can see that portion, the tight area, it was not dilating. So I went ahead with the 3.5 scoring balloon. Then also, it was not dilating properly. I went up to 16, 18 mm. It was not dilating. So again, that I after post dilatation, then I checked the IVUS. What is the result of my preparation? So after this, the patient started complaining of severe chest pain. So what I have done is that because of my aggressive pre-dilatation, there is already a significant dissection. And this picture, you can see that the dissection, and there is so much of blood in the media. So it was a very aggressive pre-dilatation, but to my surprise, that area which was calcified, it remained like the same. There is not much change, but before distal to the calcium, it was started dissecting. So I thought because of this extensive dissection, even though there is calcium and that is an eccentric calcium, I presume that after putting the stent, I will get an eccentric expansion and the area will be good. So I decided to put the stent with this much preparation. So the maximum balloon which I was used was a 3.5 scoring balloon. So based on the IVUS length, and it was a 3.3 into 48 mm stent was put. Then after that I've dilated again the proximal and the distal part. Then after putting the stent also, that middle part remained undilated. So again I post dilated with 3.5 NC to get much higher MSA, and 3.518. So then the proximal was, as per the IVUS, it was need a 4 balloon to optimize, so I did that one also. And after aggressive post dilatation also, the middle part remained undilated. Then I took the, as per my calculation, at least this was the distal area is 5.17 and the proximal area is 9.3. So at least 80% of the average area should be there to get some good result in terms of long-term follow-up. So it comes around 80% of the average is 5.7. So I was looking at whether I got this area. After the post-stenting, the IVUS was like this. And you can see that dissection is there, but the calcified area remain undilated. When I calculated the MSA, in that area it is only 3.8. Even after with aggressive dilatation, repeated dilatation, 3.5 was the maximum size that I can use there. Why? Because I was showed that EL to EL is close to 3.5. So I went up with the 3.5 and post dilated up to 18 mm. So with this, I thought that because of the fear of rupture, I stopped the procedure with this MSA. And one more time, after seeing this area, I have dilated one more time to get at least a 5.5. I was chasing the MSA like anything. I'm not scared. I was only thinking that I should get a close to a 5 millimeter square MSA to get a long-term outcome. That was the only thing which was going on in my head. So I kept on dilating. After this dilatation, everything, this was the final result. After that, I didn't do a IVUS. But the problem happened is that the patient, after 1 week, for the next 1 week, patient was completely fine. He doesn't have any chest pain. He started walking. He doesn't have exertional angina. But one thing he started complaining was he was having left shoulder pain. Every time he was saying that I'm having left shoulder pain. So after 1 week, he came to my OPD saying the same complaint. Echo was normal. All other investigations were normal. So we have given him an analgesics. Exertional angina was totally absent. First week it was that. Again, second week, he went to another doctor. It went to an orthopedician to show this I'm having left shoulder pain. I'm no chest pain and a slight shortness of breath. But on the third week, he presented to our emergency department with a severe left shoulder pain and chest discomfort, not a typical pain. So at that time, he was saying that intermittently, I'm getting fever also and shortness of breath. So I took an echo there. Echo was not showing significant RWMA. There was but some trace of thin rim of pericardial effusion, very thin rim was seen. So otherwise the LV function appears to be good. So I was not knowing what is the reason for this pain. The patient was in severe pain, left shoulder pain. Every time he says only one thing, I'm having left shoulder pain. Then I checked the RC. RC was normal previously also. And this is what the lady showed that time. There is an aneurysmal dilatation happening in that particular area where I dilated, where I chased the MSA, that area was having aneurysmal dilatation. So you can see that the changes happening here. And in the second picture, you can see previously my stent was completely opposed, but now you can see there is a clear-cut space between the stent and the vessel wall, and the blood is sweeping across it. So it was like a contained rupture, which presented after 3 weeks. Actually, the symptom was there from after the first week onwards, but it becomes so severe after third week. So what to do for this? And the patient was having fever also. His total counts was increasing, and the CRP came up to 200. So I thought there's a stentitis happening inside with an infection going on most probably. All because of my aggressive pre and post dilatation, because of that this much extensive dissection, and now it has become a contained rupture. So I told with my previous experience, there was bad experience in treating this tendinitis related complication previously. So I told them to, you need a surgical opinion to see whether any surgical intervention to be done here. Why? Because I'm not sure whether a patient can be treated medically, but at that time we don't have a surgical backup in our hospitals or refer to another center where the check angio was done by the same heart team there, and they told the finding is the same. There is no need for any surgical treatment right now. We will wait. We will continue with the medical therapy since the patient CRP and was on the higher side. The patient was getting fever. they treated it as an stentitis, probably a stentitis with an as per like a infective endocarditis. They started him on multiple antibiotics. After 48 hours, patients started improving. The pain started decreasing, but and the surgeon told there is no need for any intervention. Right now, we will medically support. But on the 5th day, the patient's condition deteriorated. Patient went in for recurrent AF with hypotension, AKE, and the fever episodes started coming very often. So at that point of time, they have decided, okay, they have done I don't have the video, they have done a check angio there. There also that the size was increasing. So they finally decided to go for the surgical opinion, and the surgeon when they opened it out, surgeon told what this is an extensive purulent pericarditis. It's not a purulent pericarditis, significant pericarditis was there. So that might be the reason why the patient was complaining of severe pain, and finally they were forced to take out the stent, and what they have seen is that it was an abscess-like dilatation happening in that area. So they completely dissected out and they sent for examination also, but it came as negative. There is no organism identified from that, and they ligated it and they put an SVG graft for that. After that only the patient's condition improved and he got discharged after 3 weeks. So this is one complication. So I think that what happened here is that stentitis happened all because of the aggressive pre-dilatation, post-dilatation. We have created an extensive dissection in that area, and followed by that is the reason why the stentitis happened to this patient. So whenever you have a doubt that the stentitis happens, and all the literature says surgery is the best option, but I don't, there are certain reports also, medical treatment can be done if you at any point of time you feel that it is not going to work, the surgery is the best option. And the patient luckily got saved and the patient is now fine. It happened 6 months back, patient is doing good.
Was the IVL being used in your case?
No, sir, IVL was not.
IVL was not used. I think IVL would have been used because of the repeated pre-dilatation. It was not giving away. So lesion preparation was, I think, should have been.
I suggest when you notice there was some hematoma after pre-dilatation, before putting the stent, you could have, even if IVL is not available, you could have used a cutting balloon. Cutting balloon sometimes cuts and decompresses the hematoma. And regarding infection, it's an unfortunate and unexpected complication. Did you use ox balloons?
No, sir, no ox was used.
No ox was used. Okay. Then it's very unfortunate, unexpected.
But the blood culture was negative. Even the sample taken from the tissue sample also, everything is negative for an infection. But it's like an immune response. It's like an immune response. It's an inflammatory thing which happened. But all because of the aggressive
multiple
dilatation.
So cutting balloon is also an option that you could have thought of before putting the stent.
Opponents. So it will add up to the pressure. I did it with 3.5 and 3.5 has created this much problem.
I just wanted to ask one thing. There was an aggressive approach to this, but it was justified, is what I feel. The message I don't think should be that you shouldn't be aggressive because there is a risk for such a thing. As long as aseptic precautions are maintained, I don't think you should ever develop such a situation, right? Because if it were stentitis, then I think the LCX stent was working fine and there is no problem in there. And usually when you stent across an aneurysm, the aneurysm seals off. It is the opposite effect that happens when you put a stent. After putting a stent, if you're getting a bulge that is increasing, your diagnosis was perfectly spot on. That you thought that there was a stentitis and an abscess, and that is probably the reason. Even the pericarditis favors that diagnosis. Not getting an organism, that is not explainable. But yes, I think the message shouldn't be that you shouldn't be aggressive. Approach is exactly correct. Somewhere around down the line, there must have been some break in aseptic precautions. We don't know that, obviously, but automatically labeling it to stentitis because the other stent is still there in his body and he's recovering. So, and it's the same brand, both the stents?
No, different brand.
Okay.
Hello, I should have avoid the stenting. If the preparation is not adequate, then the stenting should not have done.
Sometimes you will get some hypersensitivity reaction with copper chromium. in polymer also. That is the reason for some sterile.
Yeah, that is a basic. The material which is staying there is a reason for all this inflammation. They removed everything and everything become all right.
Hypersensitive reaction to this metal and polymers.
Maybe.
I think the learning point from this case has to be that you have to take a shorter stent, shorter balloon length, because you're taking 3.5, 12, 18, and because your calcium was the length of the calcium was really small.
Really small it was.
A smaller balloon, because what is happening is it's like a dog bone effect. The calcium place where you are, it's not expanding, but the rest of the other two, the proximal and distal, that is why it's causing more and more dissection.
Yes.
So the more you go higher up, the dog boning effect is there. The calcium is not yielding. The other two proximal and distal, it is getting more and more. That is causing more dissection. So a shorter, 8 or whatever, the least length of the balloon you had taken, even if you had gone much higher up, then you would not have yielded. Generally that will slip.
It was slipping. It was slipping.
But it is much safer. Otherwise, this is what's going to happen.
I tried with a small balloon, but it was slipping. Every time it was slipping.
You take slightly, if you're taking 8, then you go up to 10. But if you're taking longer one, you're going to, because healthy parts of the artery is there. That is why it will damage more and more.
Yeah, true. It's true.
Just one more point. The FDG PET in these cases, we've used it in a few cases. They will give, at least for medico-legal purposes, if you do one PET and this stentitis really lights up on FDG PET very easily. So all speculation can go away.
They were asking like it is a stent which is causing the problem. That was the allegation from the.
See, that's the problem. That's why I told medico-legally.
Yes.
Even if it is, if you do an FDG PET, if the stent doesn't light up, and if it's only the pericarditis or whatever is happening, if that's the only thing, then there is some help for us. But even if it lights up, I don't know what else can we do. Treatment is the same.
Treatment is the same. Okay, thanks.
Thank you, Dr. Jamil. Our next presenter is Dr. Suraj Kumar. The case is stent loss.
Good morning, sir. Good morning, respected teachers. I am presenting one case of stent loss. My case is 65-year-old male with non-diabetic chest pain since 2 days, present with SES anastomia with normal EF, no regional valve. RFT is normal, CAG is TVD. We plan for PTCA to RCA and LED because LCX is diffuse disease and non-dominant. So LED plasty was uneventful. Now moving to RCA, proximal RCA showing significant stenosis. So we plan for the moving to PTCA with right radial approach. Though we wire with a choice floppy wire, we directed with 2.510 SE balloon with 10 atmosphere. Now moving to stent, we took to 3.520 drug electric stent, and while adjusting the position of the stent, where a stent balloon came out, and stent is still in the proximal RCA. So we took 1.5 balloon, SE balloon, to cross the stent to retrieve the stent, but is not crossing the distally. Still here is stuck. 1.5 balloon is stuck here. So our next plan is whether with retrieve, deploy, or crush the stent. So our plan to deploy the stent, because wire is in position, and we not able to negotiate with the smaller balloon because only 1.5 balloon is available at that time. So we start dilating with the proximal to distal balloon, proximal serial dilation 1.5, 2.5, and after 3.5 balloon dilatation, this is the dilatation after 3.5 balloon stent, 3.5 balloon NC balloon. So we can see that there is a proximal migration of the stent also after deployment, and the distal deformed stent is here. So what to do next? We deploy another stent, bigger stent, 3.532 drug electric stent at atmosphere to cover the stent and the lesion. This is the final angiogram of the poor dilation with 3.512 NC balloon or 18 atmosphere. So So stent loss can occur during the PTCA. It can lead to coronary occlusion, perforation, or dissection. Stent loss either can be treated with retrieval of the stents and crushing or deployment of stent. Retrieval is often attempted, but it can lead to additional complication of perforation, dissection, and acute vessel closure. Covering it with another stent may help to prevent the migration of the lost stent. So these are the risk factors. It can be related to the patient factors, calcified vessel, tortuous vessels, equipment related poor guide support, operator related poor lesion perforation, forceful withdrawal of the stent against the resistance. There are three methods: crush of the stent loss management, crushing, deploying, retrieving by small balloon, trapping inside the guide catheter, snare. So the take home message is stent loss can happen anytime. So if the stent loss in the intracoronary artery, whether you decide whether retrieval is required or not. If retrieval is not required, if wire is in position, you can deploy the stent and crush or crush the stent. If wire is not in position, then you can crush the stent. If outside the coronary arteries, if retrieval is needed or desired, if retrieval is not required, then you can leave in the peripheral artery. If required is wire in position, then you can use a small balloon technique, which is most commonly used. And after that, if a small balloon technique is failed, then snare the stent. And if also failed, then multiple wires you can take in and fill that with guide wires. If again failed, we can ask for the surgery. Thank you.
Excellent case. Any questions from the audience?
Thank you very much for that wonderful presentation. Please, I want to know, what do you think caused the stent
I
loss?
think poor lesion preparation, because we can take for 3.5 mm vessels, we can dilate with 3 mm balloon also, but we dilate with 2.5. That may be the reason. And some old patients, some calcification and fibrosis are also there. So during movement of the stent, balloon degloves from the stent.
Thank you, Dr. Suraj.
Thank you, sir.
So now the last case of the session by Dr. Arun.
Yeah, respected Chair, friends. So we'll change gears a bit. So from all the things that you were listening about opening up vessels, now for the final case, we'll talk of how to close off a vessel and that used as a treatment. So this is a scenario where you create, can I have the slides please? Yeah, when you create a CTO to treat a disease, that is an Alcapa device closure. It's related to LMCA, probably that's why they put it in this. So stories of a 48-year-old, progressive foot angina for 10 years, recent worsening of symptoms with ECG showing evidence of lateral wall ischemia. Echo shows wall motion in the LAD territory, preserved LV function, you have mild MR. You find a dilated right coronary artery and a shunt in the pulmonary artery, suggestive of possible Alcapa. We get a CT to confirm the diagnosis. Cardiac CT confirms a diagnosis of Alcapa with extensive collaterals. The LMC is about 10 mm. The LV is dilated with reversible perfusion defect in the LAD and LCX territory with no scar. We get a perfusion scan. It shows a dilated resting LV cavity with a 20% reversible perfusion defect. 20% of viable LV myocardium is at jeopardy. So this is a 48-year-old, severely symptomatic. Echo and CT confirmed Alcapa with extensive collaterals. 20% reversible perfusion defect in the LV myocardium. We send her for the standard of care cardiac surgery. The surgeon refers her back saying that she's just not willing for surgery and she's profusely symptomatic. Try any percutaneous option. So that's when she comes back to us. So at this juncture, we think of doing a Alcapa device closure. So what's the concept behind it? Alcapa in 90% of the time is fatal in the first 1 year. Who have extensive collaterals survive into adulthood despite coronary steal. They present with angina and dyspnea, but sudden death due to the coronary steal is a potential risk in adult. In children, coronary translocation is standard surgical care, but in adult, surgeons do a surgical ligation and they give an SVG graft because of the large size collaterals. Evidence lacks in adults with extensive collateral to show the superiority of establishing dual coronary supply over left coronary ligation. So isolated LMCA ligation without bypass graft is a practice which is done by surgeons in 25% of the cases, which we try to replicate with an Alcapa device closure. We looked at in literature. Dr. Shukumar has done a similar case with the mother and child approach, where he devised a small Alcapa with the 8 mm muscular VSD occluder. So we thought of trying to replicate it, but when we do a shot, the left main is quite big. You see the RCA shot confirms Alcapa with origin of the left main just below the pulmonary valve, left lateral slightly anterior side with a sharp inferior angulation. On the angio, it's about 10 mm. The ostium of LMCA is 10 mm at the PA side. So we cannulate a right femoral arterial axis 7 French guide in the right coronary artery to inject to locate the LMCA ostium. Right femoral vein 8 French axis with a JR 5 French to cannulate the main pulmonary artery and to get into the LMCA. We get a Teflon down the LMCA and exchange it to a JR 3.5 8 French guide. An RCA chute is constantly taken to guide the LMCA deep cannulation, but the Achilles heel was an abrupt angulation from the pulmonary artery. And a JR 8 French guide, we find it difficult to track it down. We put a Teflon down the coronary, take a Grand Slam down the LAD, still we find it difficult. So we take 2 wires into the coronaries and then we dilate these balloons and track the guide deep into the left main. And we use a made in India Konar MFO occluder because it has a double-sided screw which allows for retrograde and antegrade approach, and it maintains a relatively small profile and can be delivered via guiding catheters from 4 to 7 French. And it has been proven in wide array of cardiac lesions with adequate safety, efficacy, and technical feasibility. So through the 8 French guide with deeply intubated, the Alcapa is devised with the Konar MFO 1412 from LifeTech. We check for the position on the angio-T transthoracic echo. There is a tiny device leak, but we feel it is acceptable and we release the device. The story doesn't end there. Post-procedure, patient develops atrial fibrillation. The device gets embolized in the left pulmonary artery. We recapture it with a Mullen sheath from the left pulmonary artery, get it down to the IVC. This device would not get into a 9 French sheath, so we take a 16 French Cook sheath, retrieve the device fully out, and we continue the procedure. We thought of now taking a 16 mm AVP or a 16 mm PDA device, but for that you require a 9 French sheath. But whatever you do, the 9 French sheath does not get to the acute inferior angulation of the Alcapa. The acute angle of the LMCA from the PA just could not be tracked through any sheath. So now we again do the same things again. We take a 8 French JR guide, but this time with balloon anchoring and a guide extension, we take the JR 8 French quite deep in, and we take the same device in quite deeper in. The 1412 MFO, which has an 18 mm disc on the either end, is positioned deep in this time. And this is what we finally have after we are done this. So the Alcapa gets closed. We are eventually we are converting an Alcapa into an LMCA CTO just to reduce the coronary steal. So that's why I said we are creating a CTO to treat a disease. This is the post-procedure ECG. The changes settle off. Echo shows there's minor intra-device leak. The device is in situ. This was something which we are doing for the first time, and it's only once reported in the literature as well. So we wanted to be sure what we are doing is right or not. So we get the patient back on follow-up, and we do a check angiogram after 3 months. The entire shunt is closed off. The device is fully endothelized. There is no residual shunt across the Alcapa. You can see the device is fully endothelized. We reconfirm it to the CT. We repeat a cardiac CT 3 months down the procedure. Device is exactly in position where we wanted, and the collaterals on the CT itself is well developed now. But the proof of the pudding is actually on the perfusion scan. The perfusion scan says that the LV dilatation has come down. The perfusion effect has reduced down to just 6% myocardium now, and compared to the previous study, there's significant improvement in the contractility of the left ventricle. So with an Alcapa device closure, while we convert an Alcapa to LMCA CTO, what we achieve is a class 3 symptomatic patient becomes class 1. EF has significant improvement on the perfusion scan. The LV reversely remodels. The perfusion effect comes down from 20% in this case to 6%, and the MR regresses. So the intention of presenting this case is till now only one case of such Alcapa device closure has been reported in literature. This was a person this is an adult person with Alcapa with refractory heart failure and just not willing for the standard of care, that is surgery. We closed it with the made in India Konar MFO device this is from Nageshwar Rao's lab. Actually, he has found this device, and this device is very suitable. It can be deployed from either side. We had a device embolization which was recaptured and retrieved. The same device was positioned much deeper in, and to prove a new concept, we have actually followed up with the CT, a check angiogram, and a perfusion scan to show that there is reversal of the perfusion effect, improvement in the LV function, and reversal of the remodeling process that has happened in the LV because of Alcapa. So, thank you.
I think it's an excellent and exotic case. What do you think the ideal case for these type of procedures, interventional procedures?
So ideally, Alcapa should always go to the surgeon. In only desperate scenarios where they are just not willing for surgery or there's an absolute contraindication from surgery. This is actually, they were seen in 3 surgical centers, and our own surgeon referred the case back to us saying that they are not willing, and so we had to do something. And such a scenario, as a desperate measure, you can do this. It's a very novel thing. We really don't know. We have a 9-month follow-up with this patient, clinically doing absolutely fine. Echo is normal, no symptoms now. She's able to walk very well and take care of all her activities. And the perfusion scan also shows that there's reversal perfusion effect. So physiologically, we have proven that what we have done is right, but we don't advocate it to be routinely done.
How many cases would have been done like this?
Only one case is reported. One from Triple M by Dr. Shukumar. Only one is reported in literature.
I think any question from the audience?
Yeah, so this case we just do like any of the device closures. We gave dual antiplatelet for 6 months till the device endothelializes. After that, single antiplatelet.
Sir, any intra-op arrhythmias, intra-op, post-op dislodged
Post-op,
and AF,
yeah.
intra-op, because
Intra-op,
you are
nothing.
playing so much into the coronaries.
Nothing happened because it was actually all filling from the collaterals. We are going against the flow. Nothing happened.
So do you think that the atrial fibrillation is responsible for the
No.
device embolization?
No. It was two
casual
coincidental
finding.
things. It was just two coincident things. We were not deep into the device.
Yeah.
We were not deep.
Either
That's
the
why it
size
embolized.
is less or it is not properly placed.
It
Only
was
that
not
causes.
deep in. Once you take such a case, you'll realize
Otherwise,
it's
also it would have embolized.
Yeah, it was very difficult to go deep into the LMC. It is not easy. We struggled for almost 1 hour to get deep in, and that's why we were not deep in the first time. We didn't want to dissect the LMC, and that's why we placed it up front. And we were not deep in, and that's why next time when we went in, we just went in quite deep in. AF might be a coincidental thing.
Thank you, Dr.
Thank you.
I think this is the end of this session. Thank you all the speakers for the wonderful presentation.
The next session is severely calcified lesions, 6 plus 2 minutes. The chairpersons for this case presentation session 51 are Rajiv Bajaj, Hari Om Tyagi, Anil Kumar. And the discussants for this case presentation session 51 are Harsh Vardhan, Suresh Kumar Behera, Manzinder Sandhu.
Hello? So we start this today's session on left main interventions, and our first speaker for today is Dr. V.T. Shah. Is he there, Dr. V.T. Shah? No, he's not there. Okay. Dr. K.N. Ganesh. Okay. Dr. K.N. Ganesh is going to speak on rotablation in an elderly patient with acute anterior wall myocardial infarction.
Good morning, everyone. Today I am going to present a case which is going to highlight the challenges we face in doing a PCI in an elderly patients with multiple comorbidities. So this is a 75-year-old male presented with complaints of rest angina for 1 day duration. ECG showing changes in anterolateral leads, suggestive of a drop positive and an STMI, and echo showed RWMA of LAD territory with a EF of 35 to 40%. He had history of diabetes and hypertension and minimal cognitive impairment, early Alzheimer's disease. So he underwent CABG. He underwent CAG, which showed obviously critical calcified TED as expected, with a syntax score of 33 and distal left main showing 50 to 60% disease, a large ramus showing ostial 90% and severe disease of LCX, and heavily calcified mediality lesion of 90 to 95%, and angulated LCX2. So he was advised CABG as expected. However, his son, being a surgeon himself, was unwilling for CABG, and he was continued on OMT for 1 month. So following 1 month, he had a recurrent rest angina, and now we are left with an option of obviously doing something, and they were reluctant for CABG, and then we went ahead for a multi-vessel PCI. So with appropriate strategies, and angiogram was taken, And this is what to be noted. Again, there is a decreased flow in LAD which was not there 1 month back even on optimal medical treatment. So a reduced TMA2 flow in the LAD. So this may suggest that a optimal medical management may not be suitable in patients with very tight lesions, critical lesions. So he was taken for PCI with plan of a calcium modification as visible on the angiogram, heavily calcified, with a strategy of doing a left main to LAD and probably a tap or a depth to the large ramus and leaving circ on medical management. So what was found? So a 1.2 millimeter balloon couldn't cross, following which a fine cross microcatheter taken, so that was unable to cross the lesion. So it is now a balloon uncrossable lesion, so which increased the difficulty of the procedure. A rotor wire was manually steered from the point of microcatheter where it was stuck, and then a rotor 1.5 bar was chosen. A debate may be done between 1.25 and 1.5 in balloon uncrossable lesions, but went ahead with 1.5 bar. So took multiple runs. As it can be seen, it required a lot of patience and control of adrenaline, so bar wasn't crossing, multiple resistance points, and finally the bar could cross with increasing the speed of up to 1.9 RPM. So during the procedure, patient had some hypotension which is expected due to distal embolization, some myocardial stunning, and started an inotropic support. And from here, once the bar crossed, so thought it is a straightforward procedure, but it wasn't to be. So pre-dilatation was done with an NC balloon, and a Wolverine cutting balloon was used, a rotacut strategy in view of heavy calcification. Tried to do a OCT catheter. It's not the OptiStar catheter which is available now. It was done 1 year back, so it's a dragonfly catheter, couldn't cross. So 2 overlapping Zines expedition stents were deployed using a buddy wire. Both the stents were deployed appropriately using the buddy wire technique. Ultimately, buddy wire support helped. Following this, a OCT was done to optimize the further results, and now OCT catheter could cross the segment, stented segment. The aim of having a OCT at this point of time is, considering all the technical challenges experienced during the procedure, there was a change in strategy in my mind. So wanted to stop this procedure at this moment of time and then go ahead with the left main to LAD if required, probably after 1 to 2 months. So OCT was done and stent expansion was optimized. It showed MLA of 4 and it was optimized to 4.5 to 4.7. There were no significant dissections. What we are more important is to look at the significant dissections in the proximal segment. If at all, if they are there, obviously have to complete the procedure, which was not found. So very happy at this moment of time, not using a IVL and proceeding with left main intervention in view of already requiring some inotropic support and the complexity of the procedure which was done along this period. So the plan now changed to shift. I decided to fix the major OM in this procedure so that it would be more easier for me to do a LM LAD in the later procedure. So LCX was pre-dilated, however buddy wire couldn't deliver a large stent across LCX in view of the angulation which we already experienced, which was already showed in the angiogram. Finally, a stent could be delivered across the OM with a guide catheter support. Guideliner was used, and then it was post-dilated accordingly, and good result achieved. So after doing this, at this moment of time, it is decided to stop the procedure at this moment of time. Patient was maintaining very well on inotropic support, minimal supports, and then the procedure was stopped and planned for a further procedure after 6 weeks to 2 months. But luckily he was doing very well at 1 year of follow-up. Didn't force me to do another procedure. He was doing absolutely fine. So the take-home message is PC in elderly patients with multiple comorbidities is technically challenging. Heavy calcification, as known, always poses a significant challenge for a successful procedure and long-term outcomes. Upfront calcification and knowing our tools is mandatory, is very important in increasing the chance of a successful procedure. Thank you.
Any questions from the audience? Okay, the case is well done. Priority, like prior to doing the case, you should plan it out. Like patient will require a rotablation. It's very difficult to do a rotablation in such cases, and you expect that patient is going to have slow flow. So in hand, like before, you should have a IABP in your mind also, like if the patient requires the MC support system should be there, because patient is having ACS. So definitely he is going to have a slow flow. And if you're, sometimes you have that your rota doesn't go. So you have to upgrade the size of the rota, then increase the speed of your rota, then your goes. And sometimes you have to end up with half rota also. Just it reaches up to some lesion and modifies the plug, and then you are able to take your balloon. That is the thing.
Points well taken. This is a balloon uncrossable lesion. For pertinent to this case, upgrading the size of the burr is not going to work. The probable option or the better option would be to start with a 1.25 burr and cross the lesion and then go for a 1.5 burr. But I decided to go with a 1.5 bar to begin with. However, 1.25 bar will cross the lesion in balloon uncrossable lesions, but increases the chance of a bar stuck is there with the 1.25. But to begin with the 1.75 bar, we cannot, it's not the right option here. So I think 1.5 bar worked very well, done the work.
Either you increase the speed or you can downsize also. These are the methods which are recommended if your rota bar is not crossed.
So that's how ultimately we could cross. So the third point, last point of resistance which I showed, crossed with a RPM of 2 to 1.9.
And proper preparation of bed with, like if you have a cutting OP and balloon with that, so that will facilitate in taking
the most important thing here is bed preparation in a case of a balloon uncrossable lesion like here. So only comes after doing a rota followed by probably a cutting balloon. OPN balloon, high pressure balloons, yes. So when there is a difficulty in crossing so much of hardware, even after doing a rota and cutting balloon, stents couldn't cross. So OPN balloon are cumbersome, and it would be a better option to do a post dilatation scenarios wherever when we have a minimal residual narrowing.
Wouldn't you prefer a IVUS over the OCT in such a patient?
Yes, sir, absolutely. IVUS would have been more better, no doubt about it, considering with a creatinine of 1.5 and age greater than 75, and as well as the negotiability or trackability of IVUS catheter is a better option, yes. So, but however, we had an OCT available, so thought went with, ahead with it, but couldn't cross, and finally, whatever is mandatory, could done the OCT after placing a stent and optimized the result. Yeah.
So did you consider IVL at any stage?
Yes, yes. So left main, the size of the left main is 5 angiographically. So a rota across the left main distal is not going to help. So IVL is mandatory to achieve, if at all, if we plan to do a LLM to LAD stent. So that was postponed for a later date, and it was not required.
How much is the follow-up?
Exactly 1 year. So probably last February 26th, the patient was discharged. So he is absolutely fine. So no symptoms at all. No angiography. I didn't do an angiogram.
Any perfusion scan or dobutamine stress echo or something like
that?
No,
that would be significant. Yeah, because that would be significant because we had a distal left main disease, which is already significant even on imaging. When I did a OCT, the MLA of distal left main is 4.7. So even though it is not physiologically appropriate to say that is significant, but it is less than the minimal cutoff of imaging for a distal left main disease. So even if you do a dopamine stress or a stress thallium, whatever it may be, so that it may be a significant. So the lesion is physiologically significant. We already know it. So that's why further intervention is not done, and whenever he is symptomatic...
aggressive medical management can be done in such cases. Yes, old patients, you are going to land up with issues. And if the patient becomes symptomatic for the future life, definitely he will require some intervention.
The acute culprit lesion is tackled already, so whenever he is symptomatic, we can go ahead.
The second thing was, like you said, after rota, the patient was hemodynamically unstable. There was inotropic support.
Unstable. There is some sort
he
of
required
hypotension.
some. Yeah. So I would not have done that circumflex. So I would have done that. Because if the patient develops slow flow in the circumflex, then you are really in trouble.
No, but once the LAD part is done, the flow is very good in LAD and his blood pressure stabilized.
Still patient had a MI.
So yes, MI. I had that's one my thing in mind. It would make my further procedure more easier. So I just went ahead with it.
Thank you.
Right. Thank you.
Dr. Yanpo Lin is there? No, I don't think. Dr. Pandurang Prashant? Okay. Use of guide extension catheter with balloon assisted tracking and...
So good morning everybody. So I will be presenting a patient where I will be telling about the use of guide extension catheter in severe calcified lesions. The two patients, patient 1 92-year-old male, ambulant, hypertensive, hyperlipidemic, presented with external angina and dyspnea. He was diagnosed to have severe valvular AS and planned for a TAVI, and he underwent a coronary angiogram. RCA showed some 50% proximal and RPDA 70%, left main 30% mid. Then LAD was a type 4 vessel with 80% calcific proximal lesion, and a ramus intermedius, which was short, had a tight ostial lesion. LCX was retroflexed with 90% proximal calcific tandem lesions. So he was planned for a PCI to LAD and circ followed by TAVI. So here you can see right femoral artery approach guide was XB3, whisper extra support wire, and LED was first stented after pre-dilatation with a 2.75 into 23, and part was done. Now crossing the circumflex, a bit challenging, but whisper extra support wire could cross. Pre-dilatation was done, and you can notice here two tight lesions there. So unable to negotiate the planned distal stent even with buddy wire, took 3 into 12 DES, a shorter stent with 6 French guide extension catheter support, and deployed the first stent at 16 atmosphere. And guide extension catheter was removed to prevent any device induced dissection of the left main. So next, took unable to negotiate a 2.75 into 18 millimeter stent distally. It got stuck in the proximal stent, and using 1.2 balloon removed the stuck stent with the wires after passing another wire and a balloon, and a JL 3.5 guide was taken, and post stent you can appreciate here there is some dissection. And the guide extension catheter, this is a BAT technique, balloon assisted, similar to the radial loop when you want to cross. A 2 millimeter balloon was taken at 8 atmosphere nominal pressure, but it will be hanging inside the guide extension catheter. It is not completely out or very distal, and at a nominal pressure it is inflated, and the guide extension catheter is pushed smoothly, and then the stent was taken and finally stented with good result. There is another second patient, 81-year-old elderly male. Again, he had a stenting in the distal RCA before, and he came with a non-STEMI, and his angiogram showed 90% proximal mid lesions in the 2 new lesions in the RCA. So here buddy wire was put, and distal stenting was done after good pre-dilatation. The wire was not coming because of calcification, and with a balloon, small balloon support, the wire was pulled back, and another 3.5 into 38 DES was unable to negotiate even after NC balloon dilatation from 3.5 812. So here again the guide extension catheter was advanced with balloon assisted sliding and tracking. The difference is here the balloon is kept in front of the guide extension catheter, not inside it, and it is done at a lower pressure. Usually that is done at a BAT technique is done at 8 atmosphere, here at 4 atmosphere. And when you deflate there, when you are inflated, you are pushing the guide extension catheter. Here it is deflated, and like a inchworm technique, it is pushed. Here you can see the guide extension, it is inflated, and while deflating this is pushed inside, and then after that the stent was a long stent was taken, and it was deployed, and with good results. So this was the one which was previously advised, where distal anchoring balloon and the guide extension starts coming from above. This has been shown to cause dissection, so this has to be avoided. Distal anchoring, and either the BAT or most preferably the sliding technique is a better option. So take home messages: the guide extension catheter, a mother and child, can be delivered deep into the coronary artery, provides increased support and facilitate delivery of stents. Use a balloon when you deliver a Gs to rail and center the device. You want to avoid this razor effect with this either BAT technique or the blast. The BAT is also called as balloon surfing technique. The main differences is partially protruding balloon, nominal pressure, and the extension catheter is pushed during inflation, whereas in the blast technique, it is kept in front of the balloon with low pressure and during deflation. So newer GECs are better in these cases because of soft tip and hydrophilic coating. Thank you.
Very nicely done case. Guide extensions nowadays we are using, like frequently we have to use, because you know there are calcified lesions, very hard lesions, bends. If there are bends, we have to take this. And these are the two methods by which we can take, and we were using anchoring balloon technique for taking balloon down. So in the same way we can use it. At the low pressure you do it distally take and then take your guide. The main thing is you have to take your guide as deep as possible inside your vessel and try to just reach at the lesion, or if you are able to cross the lesion, it's better. One thing I would like to mention in like your LCX case, there was a acute angle and it was not going to, without GEC, you were not able to deliver the stent. The thing is, when you put first stent, so we don't put a stent proximally and then go distally, because and before that, your bed preparation has to be very adequate. Take a OPN balloon, go to high pressures, 1:1 ratio, go to 30-32 pressure. If your bed is not prepared, nothing will go. That is one of the things. If you put the stent in proximal vessel, and there is a dissection distally, and your vessel closes, what you are going to do?
Yeah, we tried that to
So
take,
in that case, you should have taken your guide deep, all these methods, and then put a stent distally, and then put a stent at the ostial level. Otherwise, like there is a catastrophe which can happen.
Severely retroflexed, you know.
Yeah.
The guide was not at all going more than the proximal. So
Take a bigger balloon, dilate, or I would have gone for a high pressure, super high pressure balloon.
It was more of an angulation rather than preparation of the bed. So the issue was an retroflexed. It was double angulation.
So why do you think that when you put a stent at the ostium?
So proximal, what I thought, once you put a stent in the proximal, the retroflex goes. It's straight on.
It becomes more difficult actually. There are stent struts, everything are there. So I would not have done that.
But very nicely done.
So what is the size of the balloon which we should use for the sliding technique? Should it be 1:1 to the vessel?
No, it's usually a smaller balloon, 2 or 2.5. If the vessel is very big, 2.5.
Smaller balloon.
Yeah, nominal pressure 8 atmosphere, and in the blast 4 atmospheres.
Guide 5 is a better catheter, the negotiation guide 5. The smaller one, 5 French, and it goes as compared to the GEC. Okay, thank you. Dr. Loknath Sipana, Impella assisted PCI.
Good morning, everybody. Today I am going to discuss a Impella assisted chip CTO PCI. Here is a 71-year-old diabetic male who underwent PTCI to LAD and ramus in 2006 and to distal RCA in 2012, and he presented with moderate LV dysfunction. So now he presented to our hospital twice. First time when he presented with chest pain associated with breathlessness, which progressed from class 2 to class 3 over 15 days associated with palpitations. He had 2 hospital admission for heart failure. First time we advised angio, but he did not agree. Second time when he advised, he agreed. ECG was showing a non-specific STT changes, and proBNP and TROPS are elevated, and creatinine was normal. So this is the angio, this is the echo. You can see RWM in RCA territory, there is a moderate MR, there is a PA pressures are 78 plus 10, 88 are the PAH. So this is the angiogram. You can see the ostial LCX lesion. You can see the occluded ramus, and you can see a good flow in the LAD. And there is a RCA, mid RCA, there is a CTO. You can see the distal stent also got occluded. So these are the risk scores. Syntax score showing PCI risk of 16, CABG 14, euro is again 15.86 predicted risk of mortality. CHIP CTO score for protected PCI is 10, JCTO score for RCI is 2. This is how CHIP score is calculated. It takes into account the patient comorphs, the complex high risk PCI, hemodynamic compromise, there is a complex coronary artery anatomy. So in the heart team discussion, in view of advanced age and high surgical risk score and dynamic nature of the MR, we planned a protected PCI. So in the discussion, so when we planned a protected PCI algorithm, this is the syntax score was more than 22. There is a systolic blood pressure borderline at less than 100. It is a ACS presentation. We are planning to do a revascularization of 2 territories, and if at all needed, we need a retrograde CTO intervention for RCA, and there is a severe MR. So we need to strongly consider the Impella. So our plan of action was to prepare pre-procedure right heart catheterization. We want to put an Impella CP, and we want to fix the LMCA LCX bifurcation first and proceed with antegrade RCA CTO with antegrade wire escalation. If it fails, we need to go to retrograde PCI through septal collaterals, and we want to do RAMAS ISR because it's a long stent and it's supplying a very small territory. So we want to leave it on medical management. So we pre-procedure right heart catheterization was done. The PA pressures are good, and CVP is 4. Impella was inserted, and we can see the Impella flow is good. So this is a baseline ECG. You can see the ostial LCX lesion. We have done IVUS from the LAD, and we want to fix what the strategy for the LMC bifurcation is. We have seen the stent strut that are extending up to the LAD ostium. So we decided to go with mini crush. So this is a baseline LAD ostium MSA. So proximal LAD and mid LAD MSA. So the lesion of LCX was prepared with 2.5 into 15 NC balloon. We have done a kissing balloon, and IVUS to LCX was done, which you can see the proximal LCX, there is a 360-degree calcium, and proximal LCX size, ostial LCX, it is 3.18. So because it is a L6 ostium, there is a calcified. We have done a score flex with 3 into 10. We have done angio now. Angio is fine. You can see the breaks in IVUS. LMC to LCX was stented to 3 into 23 in Zions Alpine. So next we have done a crush. We have recrossed. We have done a pot and repot, and this is the final result of the left system. These are the areas of the left system. So coming to the legs, this is a dual injection for the right system. The stents, you can see the stent struts here, and there is this is the proximal RCA, you can see. So this is anatomicogram. If we want to try the antegrade wire escalation by keeping a microcatheter up to the here, and we want to take a guide directable wire, because the stent struts act as a marker for us. So we want to take a directable wire and go into the stent struts and seeing in two 90-degree positions, locations. You can see the left system showing septals filling the PDA retrogradely. So we have taken a Corsair microcatheter with Corsair Pro. We have parked in the distal RCA, and we have taken ankle balloon into the RV branch. We have initially tried with Fielder XTR. We did not go, so we exchanged with Gaia 2. Gaia 2 also did not work out, so we increased the tip load to Gladius Mongo, and with Gladius Mongo it worked out. And the distal craft crossed with the Gladius Mongo 14 wire, and we confirmed in 2 locations. So after this, we have exchanged the wire with the workhorse wire, and the guide extension we have taken for the support. It crossed the RV branch. So 1/10 balloon could not cross. So at this point we decided to go with laser, and laser we have done. At this point suddenly patient developed sudden hypotension, and we have taken angios. Angio was showing a slightly decreased flow in the RV branch because of this guide extension, and we have seen the left branch, and there is a VA coupling. We have given fluids, and after seeing all these things we have dragged the we have pulled back the guide extension back into the proximal RCA. Now you can see the flow and the hypertension it improved. So next we want to open up the PLVB branch. PLVB attempted to recross the Crusade microcatheter, and we crossed it, and PLVB lesion is pre-dilated in 2x10 NC balloon, and the stented. The mid RCA was stented to 2.75 into 33 Zines, and distal RCA to PLVB was stented 2.5 into 12 Zines. So this is the final RCA result. So these are the areas on IVUS. It's a good areas. So post-procedure patient was fine. Lactates were good, urine output is good, and so we have removed the impella, femoral site is good. TPI we have removed, residual syntax score was less, is 5. The post-procedure, the whatever moderate MR was there, it became mild. Patient LV also improved better. So take-home message: in high-risk patients with complex coronary anatomy, impella-assisted PCI helps to maintain hemodynamic stability and allows for complete revascularization. In patients with ischemic MR, complete revascularization may result in reduction of MR severity and overall good patient outcome. In balloon uncrossable lesions, examinal laser is very useful tool for plaque modification. Thank you.
You managed it well. How much was the pulmonary artery pressure before you said CVP was 4? But how much was the pulmonary artery pressure, systolic and diastolic?
Sir, on hemodynamics,
yeah,
it is.
You did the right heart catheterization,
yes,
and you said CVP is 4.
Yes, sir. Sir, 27 and 12, sir.
Very nicely done case, real chip case in such a scenario. Intra-aortic balloon pump hardly works in such cases because it hardly unloads the LV, so it has to be a impella. You had done IVUS in the left side when you did. So there is a neo-intimal hyperplasia at the LCX ostium. The stent is there. There is no stent fracture, no malapposition. So what was the need of putting another stent there? Like you use a cutting balloon, Wolverine balloon, Scoreflex balloon, and you can do you could have done a depth there.
Yeah, it is also
so
good option.
see, there is already a ISR, and you are putting another layer of the stent.
Yes, sir.
So this patient again developing a ISR in future, it increases multiple layers of metals, because it was a very small stent initially also. So this patient is very prone to get. So either there is a geographical miss when the stent was put, but it seems that there is a neo-intimal hyperplasia. So I would not have put a stent there. It's better not to put a stent, do a dep and leave it. You get a very good result because you already have a OCT, IVUS or OCT with you. Otherwise, like the case is done very nicely. Any comments from the house? The same thing with RCA also, like one stent inside another stent, already so much of metal is there. You could have just put proximal stent overlapping that. That would have been better, I think. Otherwise, done. Only issue is with the cost. Impella is very costly.
The pressure was not very high, as I can see. Echo was high, but your catheterization pressures were not high.
You said patient is having CVP of 4, so such patient will require fluid.
Even the pulmonary artery pressure, he says, is 27.
So if CVP is 4, LVEDP is also on the lower side in such patients.
So did you think of not using impella at that stage when the pressures were manageable? You had already made up your mind. Okay.
Thank you so much. So I think this was the last case.
Is Dr. Viveka here for his case? PCI with impella?
I don't see Dr. Viveka.
No, but no. Okay.
So we close today's session. Thank you very much.
you.